Deputations there. And the title of that issue is Developing the Toronto Indigenous Health Strategy. So we'll hold that for deputations, if nothing else. 8.4 is the 2015 influenza update. There are no deputants there, so it's up to you to hold if you wish to comment. Okay, seeing none, moved by Councillor Cressy. The staff recommendations, which is it's actually to receive the report for information. All in favor, opposed if any, that's carried. 8.5, update on extreme heat and maximum indoor temperature standard for multi-unit residential buildings. We do have 2 deputants there, so we'll hold for that purpose. 8.6. Do we have a presentation on this? No. Okay. 8.6 is the 2015 Pan Am and Para-Pan Am Games Summary of Toronto Public Health Planning and Operations. It's here for information, but really we should say a big shout out and a thank you to public health staff. How do you know that public health did a good job? No crisis. There wasn't a single story in the media. You know, when the Rhodes people have a great Pan Am Games, they get all kinds of kudos for this and that. We get kudos because nothing happened. And that's... Yes. Thank you for starting that. Yes, but we feel good in our hearts because we know no one got sick and everyone did the right thing, and it was just a wonderful event, and public health had its part. So moved by Elisa Levy to receive the report. All in favor, opposed if any, that's carried. 8.7, Board of Health self-evaluation. There are one recommendation there. Thank you everyone for participating. This is a good thing that I think we do every 2 or 3 years, or every term. 3 years? 2 years, to make a good board even better. So all in favor of those of the recommendation, moved by Paul. All in favor, opposed if any, that's carried. 8.8 is the Toronto Public Health Capital Budget Variance for the 9 months ending September 30th, 2015. Moved by motion to receive. I'll go on this side. Councillor Doucette. All in favor. Opposed if any, that's carried. 8.9. We do have a deputant there, so we'll hold for that purpose. 8.10 is the 2016 Toronto Public Health Operating Budget Request. And we have a presentation there. So we'll hold for that purpose. And that covers the presentation also covers the next one, which is the capital budget request as well. So we'll hold those 2 for that purpose. Next is number 12, which is the schedule of meetings for 2016. Everyone's good with that meeting schedule? Great. Okay, moved by Ashna. Bowery. All in favor. Opposed if any, that's carried. The next issue is HL 8.13, and that is infection control training and certification of personal service settings. It's just a note from the Licensing and Standards Committee that recommended it be forwarded here. Anyone to hold that? No? Okay, so move to receive. All in favor, opposed if any, that's carried. And lastly, 8.14, the local councillor who wrote the letter, Councillor Ainsley, is here for this item. I asked staff to put the recommendation that has been worked on between himself and the medical officer of health staff, and it's before you here, and it's basically to forward this request to Toronto Central Local Health Integration Network and request that a response be provided to Councillor Ainsley in consultation with the 4 other LHINs now serving the City of Toronto. Does anyone want to hold this item? Even just to make sure that he stays here all afternoon and listen to the conversation?
I was going to stay anyway.
You're going to stay? Okay. We won't impose that on you, so moved by Stacey Berry, the motion before us. All in favor? Opposed, if any? That's carried.
Thank you, everyone. I want to thank Dr. McEwen's office as well for all the assistance with this
Great.
to date.
Thank you. You're welcome to stay, but I got a feeling you're going to leave. Okay, so we are on to 8.1, which is the action on intimate partner violence against women. Dr. McEwen, staff presentation, and then we'll go into deputations.
Thank you very much, Mr. Chair. This is a very important issue which is worthy of the board's attention, but in addition to that, it has a particular meaning for my colleagues and I at Toronto Public Health, and I'd like to dedicate this report to the memory of Zara Abdil, who was one of our Toronto Public Health nurses. She and her sons, Faris and Zain, were killed almost exactly a year ago, and the board was kind enough to recognize it at the time with a moment's silence. I also want to reflect that in a few days it will be the National Day of Remembrance and Action for Violence Against Women on December 6th, in which this issue has prominence in our thoughts across Canada. So intimate partner violence, as framed in this report, it is, as defined by the WHO, a form of gender-based violence characterized by an imbalance of power between victim and abuser. It can take a number of forms, as listed in the definition, and it can occur in a variety of different relationships. It's important to recognize that this type of violence does not only affect women, it also affects men, but women are disproportionately affected in terms of frequency and the severity of violence that happens. And so this report really focuses on violence against women. In the Canadian context, about 1 in 3 women have experienced intimate partner violence in their lifetime, so it's very likely that there are women that all of us know who have experienced this. On any given day, about 6,000 women and children are living in shelters to escape abuse. That's about 400 a day here in Toronto. And a woman is killed by her intimate partner across the country every 6 days. So a very significant burden of illness. Often this starts in youth. 1 in 10 teens, according to local surveys, have experienced abuse. And among one survey of grade 9 to 10 girls, you see the numbers here, 1 in 2 had been verbally or emotionally abused, 1 in 3 sexually and physically abused. So this is very common and it starts early in life. We don't have as much detailed information and data as we would like on this topic, but we do have information from police reports, which is going to be an underestimate of what's actually happening in the community. These are only events that come to the attention of police. And according to police data, the rate of intimate partner violence is higher than the rest of Ontario, a little bit lower than Canada. And as you can see, much more significantly higher in women than in men. IPV, intimate partner violence, sometimes has fatal consequences. In Toronto, over a 10-year period, about 6 women per year were killed as a result of IPV. So this is the most severe manifestation of intimate partner violence. There are many consequences, both health and public health. Women who have experienced abuse can suffer immediate, short-term effects, including injuries and death, which are the ones that we've counted in the data I've just presented. But there are also chronic physical, psychological, social, and economic consequences that can persist even long after the abuse has ended. There are also health consequences for children who are exposed to intimate partner violence in the family. Children can experience a range of physical and mental health issues that may put them on a negative developmental path, including becoming either future perpetrators or victims of abuse. There is, of course, also an economic burden. It's been estimated in one study at about $7.5 billion per year in Canada. This includes service utilization, lost productivity. We all have a responsibility to address this issue. And it's a complex problem requires a comprehensive approach with extensive collaboration. Many sectors and organizations need to be involved and already involved. Some of these images reflect initiatives and organizations which are working on this issue. There has been, I think, heightened attention to the issue in the past decade or so, with a number of high-profile government and community-led initiatives. Recently, the Ontario government has launched an action plan to eliminate sexual violence and harassment, and we certainly appreciate their emphasis on the issue. This report focuses mostly on things that we can do as an organization in Toronto Public Health. There are advocacy recommendations, which I'll speak to in a moment, but we can add to the efforts that we already have in place to make an impact in 3 areas: on the prevention, primary prevention of intimate partner violence, early identification to ensure that violence is identified early, and response to support those who are affected. In the area of prevention, clearly we are already a major player in parenting education support, and that plays a role in setting the right family circumstances and identifying when risk occurs. We can expand education on healthy relationships from middle childhood to adolescence, and I presented the data that shows that these issues begin early in life. And we can, through a variety of different programs, address social and cultural norms that serve to perpetuate intimate partner violence. In the area of early identification, we want to increase the capacity of our staff and their knowledge and awareness to identify and respond to clients who we see. We may not be seeing them because of intimate partner violence. We may be seeing them for a completely different reason, but there's an opportunity to identify when that violence may occur. We want to ensure that there's equitable access to all of our programs and services, particularly for women affected by intimate partner violence. We want to increase our capacity to address it in the workplace. And we want to increase the public's capacity to identify and respond through education. In the area of response, we can increase and advocate for increase in access to resources and services that women can turn to for protection, support, and empowerment when they are at risk. We can also foster coordination and collaboration, and we can be one of those organizations that collaborates and coordinates. And there is still a need for improved surveillance and research. The actions that Toronto Public Health will take are outlined in the report. The recommendations focus on things that we identified in the course of developing this report that are relevant to other organizations. So early childhood development, funding can be boosted for that. Our own early childhood development programs have been flatlined in funding for a number of years now, and we know that those programs can play a role in early intervention. But having teachers have better skills and knowledge to enable them to identify intimate partner violence and its consequences, improved access to housing, reviews of police and justice responses, which may not always be helpful, and better access to legal support for women at risk are among the recommendations. We also talked about, in the recommendations, increasing access to social supports and mental health services, improved local data on intimate partner violence, and really a national action plan which would bring together efforts across the country. I hope, Mr. Chair, that this report honors the memory of our colleague and lays out clear things, clear actions that Toronto Public Health can take in its role as a public health service provider and advocate, and provides some recommendations for things that we've identified that other sectors can do in order to address intimate partner violence. Thank you.
Thank you very much, Dr. McEwen. We'll take a pause in terms of questions for the doctor until we hear from the deputants. Okay, so we have 2 deputants on this. We have Harmy Mendoza, who is the Executive Director of the Women Abuse Council of Toronto. And then we have Tim McGuire, President, QP Local 79. So there are about 15 deputants, 10, 15 deputants on a variety of items today. I'll say it once. So if for those who aren't aware of the rules, we try to be fair to everyone, and fairness in this context is defined as 5 minutes. So at a few seconds before 5 minutes, I kind of go like this and give you some hints to wrap it up. Then you may have questions from the board. So you might want to just stay in your seat for a few seconds after that. Then I'll invite you to take your seat back. So 5 minutes, it's up to you. Welcome.
Thank you very much. Good afternoon. My name is Harmy Mendoza. I am the Executive Director of the Women Abuse Council of Toronto, or Women Act. Women Act is the city coordinating committee with a membership of 28 diverse organizations, including Toronto Public Health, Ernestine Shelters for Women, Toronto Police Services, etc., etc. I'm glad to be here today as the urgent need to address the matter of intimate partner violence against women has been one of the focuses of Women Act for the past few years. First of all, I would like to draw attention to the dedication stated in the summary of the report submitted to you. This report is dedicated to Sarah Abdille and her sons, Fares and Sain, a public health nurse murdered by her husband. Sarah's husband tumbled from a bridge above the Don Valley Parkway a few hours before investigators found his family's bodies. I believe Sarah and her children's deaths were preventable. I also believe the recommendations suggested by the medical officer of health could increase the possibilities of ensuring that we prevent other similar deaths in our city. It is clear that with each consecutive generation, society's most disturbing issues are not disappearing with time, but rather intensifying. One such issue is the prevalence of women abuse, which includes far more than the physical abuse it has traditionally been associated with. Woman abuse is a crime. As a society, we must not assume that every woman enjoys the luxury of a life free of violence, despite every individual's right to such a life. A practice of zero tolerance not only needs to be implemented, but enforced in a vigilant effort to defend this basic human right. The urgent need to address this matter has been the focus of the Women Abuse Council of Toronto's efforts. Opening dialogues on violence, it's an excellent starting point, especially when we understand that woman abuse is about power and control and can be manifested both physically and psychologically. I am here today to support recommendations stated on this report. Women Act recognizes and applauds the medical officer of health for recommending ongoing collaboration with other city divisions in order to identify opportunities for implementing the Intimate Partner Violence Action Plan. The issue of violence against women is complex, and it will require working in collaboration internally within the city's department and externally with other provincial, federal levels of the government, as well as key stakeholders providing services in the city of Toronto. I would like to particularly highlight the importance of the recommendation requesting that Toronto Police Services reviews current policies in place when addressing or responding to intimate partner violence. Women Act, in collaboration with other coordinating committees working in the province, have identified concerning trends and impacts related particularly to mandatory charging. Mandatory charging is a policy introduced across provinces with the good intention to remove the responsibility from the victim to lay charges. Although the policy was intended to increase reporting, laying of charges, and reduce reoffending, concerns have been raised about the unintended consequences of this policy for women in cases where they have been arrested and charged either alone, sole charging, or with their partner, dual charge, when acting in self-defense or trying to protect themselves or their children from abuse. Reviewing the impact of mandatory charging is also one of the recommendations that came out of the Transforming Our Communities report. This report was coming from the Domestic Violence Advisory Council for the Minister responsible for women's issues. They place particular emphasis on conducting an intersectional analysis to consider the impact on particularly marginalized community of women. The anecdotal trend is felt all over the province. Women Act, in collaboration with the Ottawa Coalition to End Violence Against Women, and more or less 46 other coalitions are currently exploring the possibilities to engage on a province-wide research about the impacts and effectiveness of mandatory charging. Lastly, I would like to strongly support Goal 9 of the action plan, foster coordination in collaboration with community stakeholders. Thank you.
Thank you very much. We appreciate your comments. Are there any questions of the deputant? Okay, there are none, which means it was a good one.
Okay.
We invite you to go back to your seat, and we'll invite Tim McGuire, President, CUPE Local 79. Welcome, Tim.
Thank you. Again, my name is Tim McGuire. I'm the president of CUPE Local 79, which represents City of Toronto employees delivering services on your behalf to Toronto's communities. And I want to thank you for the opportunity, and I want to thank the Board of Health for bringing forward this report on intimate partner violence against women. And particularly, I want to thank you for dedicating it to the memory of Zara Abdillah and her sons who were killed a year ago this weekend past. Of course, she was a public health nurse, but she was also a member of my local, CUPE Local 79, so she was a sister to us. And it was a very difficult, emotional period. I, as others in the room, went to the funeral, very emotional period at the funeral, but thereafter in the local. So I can't stress enough how important this report is. It's critically important. We must do everything in our power to prevent tragedies like this from ever happening again, whether it's a city employee or anybody else in our communities. The city, the province, the federal government, and CUPE Local 79 wants to assist in this project, do as much as we possibly can to avoid these tragedies, tragic violent incidents. There's so many recommendations in the report that could be spoken to. They're all good, and we have some thoughts on how they could be even better from our perspective, but I want to speak about one, and that's the issue of legal supports. My understanding from our interactions with Zara in 2014 was that she took a second job in order to pay for legal supports because they weren't sufficiently available. Zara did meet with the city around her issues. And while I would say the city did some things right, and I can't get into all the details, there probably could have been more that was done from the perspective of her bargaining agent. So the city has a policy on domestic violence, which talks about if it becomes aware as an employer under the Occupational Health and Safety Act, comes aware or ought to reasonably to be aware that domestic violence was likely to expose a worker to physical injury, the employer must take every reasonable precaution for the protection of the worker. And the report, I think rightly, talks about the need for education and training in violence in the workplace, implementation and further supports. I think page 11 of the report goes into detail about, in consultation and talking to city employees, this was one of the main pieces that's with absence. The recommendation that talks about working with the Occupational Health and Safety Committee is important. And ensuring that it's consistent with legislation is one point. There could be other points. But I would suggest that the city needs to make sure, and at one point, it shouldn't be just the Occupational Health and Safety Committee, which I think is the broader Health and Safety Committee, the Joint Committee. It should be committees, workplace committees, which actually have the legal foundation for making changes to city policies around health and safety. The city can be a leader in driving change to protect women, and I think one of the things it ought to do as a minimum is look at the bill that has passed first reading in Queen's Park, and that's Bill 132, Sexual Violence and Harassment Action Plan, supporting survivors in challenging sexual violence and harassment. So it's coming. Let's be leaders and make sure that we're consistent with that bill that should pass the House after further readings. One of the goals of the report by the Toronto Board of Health is to increase the capacity of Toronto Public Health to address intimate partner violence in the workplace. When Bill 132 is passed, it will change the definition of domestic violence under the Occupational Health and Safety Act, and the city will need to reassess its policies, awareness, and implementation in that context, so let's do it proactively. And I want to talk about another piece of this puzzle in terms of how to move forward, because we have to learn lessons. Local 79 and the city worked collaboratively at the bargaining table for a number of rounds to make sure that there were supports and protections for our employees, sorry, your employees, our members in the workplace. I played a role in that because I was a man who decided I needed to be on the Domestic Violence Committee because I know people in my family and colleagues who have been victims. And I wanted to make sure that I played a role. So the background is we did this. We worked collaboratively at the bargaining table to put language on supports in our collective agreement. Sadly, in 2012, when Local 79 was presented with a final offer by our employer, because they refused to bargain, they refused to have a discussion about many matters, but specifically they refused to have a discussion about domestic violence, that's not there anymore. There are lots of lessons for collective bargaining to come out of 2012, but one of them is to work collaboratively, and I'll just say, finally, it's so important again that this report is coming forward, and we have to work to make sure all city divisions provide a safe workplace for their employees, not only under the Act, but beyond. And to borrow from the labor movement in terms of health and safety, it's important that we, quote, we mourn for the dead, but that we fight for the living. Let's fight for people in situations like Zara was.
Thank you very much. Any questions of the deputant? Sorry, go ahead, Councillor Cressy.
Thank you. Just one, and I understand there are some details that you can't share, but just following up on what you're talking about around the legal expenses, are you suggesting that the recommendations here could be strengthened in order to address those?
I'm suggesting, yes, the recommendations could probably be strengthened around that to make sure that it can be strengthened and make sure that the city as an employer, acting like a lead employer, a model employer, can provide its employees with whatever the appropriate supports that are needed, including legal supports, psychological supports, other supports that could be there.
Okay. Thank you, Tim.
Great, thank you very much.
Thank you.
Okay, we have questions of staff now, and we have, I see two visiting councillors. Councillor Ainsley, did he leave? Did he leave? Okay, do you have any questions of staff? Councillor Kristen Wongtam? No?
I just wanted to speak to the report.
Okay, okay, from the board itself, any questions of staff? Councillor Cressy?
Just a couple. So the report identifies the need for city staff for training on the city's policy around domestic violence and intimate partner violence. How are staff currently, city staff, made aware of the policy as it exists now?
I'm looking for some specifics. I have a general answer, but I'm hoping there's more specifics.
Hi there.
Hi.
I'm DM Mattis. Right now, my understanding is that as policies come forward, we are introduced to them via our teams, and I think it's up to each division to set up training for its own staff. I know in our division there was some limited training, but based on our consultations, people felt that it was insufficient to really feel comfortable addressing the policy and in a consistent manner.
Okay. Well, I guess then following up on that, because one of the recommendations is around intimate violence training to be incorporated into the TPH divisional strategy. Can the Board of Health make this recommendation for all city staff as opposed to just the one department?
Yes, you can. Generally, the Board of Health doesn't give direction to city staff, but in terms of an advocacy recommendation, you could make that known to the city manager.
Okay. And then I guess one final question. I know recommendation 1 speaks to the implementation across city divisions, SSHA and others. Will TPH be coming back with an implementation plan around when and how that will be done? I just want to ensure that an incredible amount of work and strong recommendations have gone into this, and I'd hate to see it as a policy that sits on a shelf.
No, we are committed to implementing the action plan, which is contained in the report. The actions are at different stages at this point. If the board would like an update at some point, I think we'd be happy to provide that.
Okay, thank you.
Thank you. Seeing no further questions, speakers, first outside city councilors, Councillor Wong Tam.
Yes, thank you very much. I wanted to thank the Medical Officer of Health for this report. I think that, you know, Zara Abdil is her name has been mentioned many times in our building, and I recognize that she was a member of the public service, a member of the Toronto family here at the City of Toronto, and I have personally mentioned her name and the situation that she was unfortunately facing, along with Ferris and Zane, her sons, in a number of speeches that I have now delivered around the issue, specifically around gender-based violence. And I think one of the important things about this report, which I believe is a great starting point, but it can't be our final destination, because I believe it can be stronger, and I'm hoping that that when the report goes to City Council, I'm going to have a little bit more time to review the recommendations, because I'd like to strengthen it even further on the floor of Council. But what we're really dealing with here is a system failure. And the system failure actually belongs here at the City of Toronto, because here she was, a Toronto employee working in health services, public health services, someone who's actually providing assistance to members of the general public to gain access to city services, whether they be emergency shelter supports, whether it be affordable housing, nutrition, access to education for our children. There's all sorts of ways that our services, the public services, intersect with one another. And yet, a member of our family was not able to access the services that we are tasked to deliver equitably to all residents in the City of Toronto. So the system failure actually belongs right here in this building. And I think that what I have now learned in trying to understand where we failed Zara and her family is that it has to go much higher and much broader beyond working with just SSHA or working with the other soft human services. This needs to go to the city manager's office, and it actually needs to go across the corporation in all the divisions, because it's not simply about whether or not we deliver service to residents in an equitable way, which we clearly are not, but it's also about making sure that the corporation and those in management positions here understand and know how to identify when someone in our immediate family is looking for assistance. And that goes right across all the divisions, and it goes into Toronto Hydro, it goes into the utilities divisions, it goes into water, it goes to Toronto Public Service, Toronto Police Services, ambulance care, you name it, and it needs to go across the corporation. And I think it would be rather limiting for us to only focus on what SSHA can do, or perhaps what can Parks, Forestry, and Recreation can do. It really needs to be a corporate overall, an overall corporation review. And that's something that I'm very interested in making sure happens when this report moves forward. The other component is exactly what Tim McGuire had mentioned in terms of when we strip away rights and supports for employees through bargaining, it has impact. And the impact that it had in this case is that perhaps Zara could have received more assistance than she was able to get. And this would have made a difference of whether or not she's still with us today. And so if Toronto is going to be that model employer, that model city where we actually really deal with the issues around gender-based violence, then I think we need to do even more than what is contained in this report, and we have to go above and beyond. And I think it starts with a recognition that we failed one of our own, and if we failed one of our own who is actually able to understand the range and sweep of services that the city offers and still not access those services, the sweep of services, I can only imagine where we're failing residents who don't speak English, who don't know where those supports can be found, and a whole host of other systemic barriers that are there. So the intersectional analysis has got to be there, but we have to fix this problem internally, and that's where I think we need to begin. Thank you.
Great, thank you very much. Okay, we'll take it, we'll take your comments. Right now, it's not being sent to council, but I have a feeling that that might change in about 0.2 seconds. Councillor Doucette.
Thank you very
We'll
much,
go around the
Mr.
circle.
Chair. That will be changing. My motion is to make sure that all this report goes to council. In item 6, it's also talking about relevant city divisions. I wonder actually if we want to remove that word relevant and send it to all city divisions. That's not in my motion, but it might maybe come as me making myself a friendly amendment. It is important that everyone sees this report. I read it through on the weekend, and actually first I want to thank staff. Very in-depth and very educational report. I was reading it on the weekend, and I was talking to my daughter who's at Queen's University, and she's doing a paper right now on this topic. And her topic is, what are we as the governments doing to eliminate this kind of violence? And so I told her to read our 10 goals, because they're good goals. And she says, oh, no, I'm looking at the province and the feds. I said, no, look at what we're doing in the city where you grew up. You know, read this report. I learned a lot. I learned a lot of shocking details which I wasn't aware of. I didn't realize that, you know, so many girls in grade 9 and 10 have experienced something at that young age. I think that's horrific. And we often hear that if someone experiences it as a child, they think it's normal. And then if it happens to them, maybe they're not reporting it, because that's what life is. You hear that with other, you know, people who take drugs, people who are alcoholics. They think it's the norm. And we've got to be out there educating not just the residents, city council, actual councillors, and our own staff. How do we see these signs? How can we help residents, people we meet in everyday life when we see these signs? We can't be turning a blind eye, whether it's a young child or whether it's a mother protecting her children. What I was shocked also in this report, saying that I've lost the page right now, but there was 20 women, I think it was, with 15 children were turned away from a shelter. Where do those women go? I'm not going to call it home, but they had to go back to a place where they live, where the abuse is happening. That hit hard. I thought that was appalling. So we have to make sure, and not just our level of government, all 3 levels of government should be putting more money into our shelter system so abused women have somewhere to go. No one should ever, ever be turned away, whether they're single, just a woman on their own or a woman with children. I also thank you to the deputant talking about how we've got to work with the police with this mandatory charging. I actually had to read that part about 3 times to get my head around what was meant to be a good policy but isn't working. So women are being arrested, being given a criminal record for protecting themselves and their children, which in the future could prevent them getting a job or getting custody of those children they're trying to protect. So I do understand it was aiming in the right direction, but if it's not working, we've got to work on that immediately, because that is so, so unfair. I've already touched on the point about the number of the girls between grade 9 and 10. I spent a lot of my volunteer time before I became a councillor in schools. And if I looked around classrooms and said, wow, X number of these girls have experienced something like this, I think it's shocking. I really do. So I do want to thank staff. It is an eye-opener, but I want more people's eyes to be opened. I do read these reports. I do come to these meetings, you know, knowing what we're voting on and things. But it needs to be spread far and wide. It shouldn't just stay in this board. I know we're going to have more motions sending it even to further afield than council, but I agree. We've got to make sure as a city that we protect our workers and we protect our residents. So thank you very much. My motion is on the screen. So there's a lot of different words going in to make sure it does get to City Council and all city divisions. So it's not just a one-word motion, and we're actually having to incorporate it in everywhere to make sure it does get there. So I'm sure I'll have unanimous support on that one. Thank you.
Question of the previous speaker, Councillor Cressy.
Which is the part that's changed? Sorry. That's the full motion, I see.
It's the whole motion, and at any point we have to send it to City Council, that is where we are including everything.
I'll ask the clerk to highlight.
I might actually get the clerk to highlight, because she probably knows far better. I know what I want to do, and then the clerks are
City
very good
Council?
at putting it into words. So it is
It's
the
the first
Okay.
sentence in recommendation 1. Okay, thank you.
Get it out there to everyone.
And she's getting rid of the word.
Oh, that city council has
Yes.
been
And I'd
incorporated
like
into
to-
all the recs.
And in item 6, I'd like to remove the word relevant, so it goes to all city divisions. That's my own friendly amendment, if that's okay. Thank you.
Divisions, agencies, boards, and commissions. Okay. Okay. Yes, right here. Stacy, floor is yours.
So I have a motion that I'd like to move forward, but I'd also like to speak to the motion.
Yeah, absolutely.
So my motion is to forward the report to government ministries that provide programs or services to groups of women, youth, and children who are vulnerable and more likely to experience violence. So that's it up there on the screen. So I'd like to speak to this motion. Government ministries tend to work in silos, yet they directly or indirectly address some of the root causes of violence against women. Sending this report to the above listed ministries will support a more integrated approach to addressing violence against women. Many of these ministries also fund programs that engage men to prevent violence against women, which is one way to address the problem, according to the report. It is important for this report to be reviewed by government ministries that provides program and services to vulnerable groups of women, but should also be extended to ministries that provide services to youth and children who experience family violence. The report indicates that vulnerable groups include Aboriginal women, women with refugee or non-status, LGBTQ, and newcomers, but should also target women within the criminal justice system, racialized women, and women who are socially and economically marginalized. I feel that this will ensure a more equitable approach and make services more accessible.
Thank you very much for your motion. Any questioners of the motion or the mover? Okay, seeing none. Ashna, you're next.
It's just a point of clarification. I think it also needs to go to the Minister of Women's Issues.
Okay. I think that's, yeah, she's accepting that as friendly, so I think that's going to be in. Okay, thank you. Ashna.
I just have a quick comment just to give more of a clinical perspective to the issue that we've spoken to. Thank you to everybody for speaking today. As some of you know, I look after patients within the inner city population here in Toronto at St. Mike's, and a lot of my patients come from these higher risk group people, so the newcomers, sex workers, patients with disabilities, those who are pregnant are certainly more vulnerable to be affected by intimate partner violence. But often myself or the healthcare team are the first people to identify violence in a home, or first people to notice that children are not developing as well as they should and try to identify some of the issues that are going on at home. And we're often limited on how we can support our patients sometimes because of the infrastructure that we're working with. So we rely very heavily, for example, on programs like the Healthy Baby, Healthy Children's program, which is fantastic. But we need a little bit more of that support across the board. You know, Councillor Doucette, you were talking about securing a safe place for women and families to go to. Sometimes that is the rate-limiting step for us to provide holistic primary care to our patients, because we don't have adequate transitional housing for these patients, and they're going home. And we're very vigilant of this, but we can't provide that comprehensive service, I think, until we have something more robust in place.
Great, thank you very much. Going around, Councillor Cressy.
Thank you. I have a motion, if it can be put up, and this is to direct the Medical Officer of Health to report back to the Board of Health in the third quarter of 2016 on the progress of the implementation plan. I'll be supporting the other motions that have been moved. I just want to ensure that this isn't a strategy that we adopt once and sits on a shelf, but rather that we see across all city divisions and ABCs that it is actually being implemented. I'll keep my remarks rather brief. It goes without saying around this table that it's a critical issue. The numbers, the shocking numbers, which unfortunately aren't shocking for many, are listed in the report, but I think as was indicated off the top, the numbers have a human face, and that face was a member of city staff and a local of QP 79. And if that doesn't demonstrate the faces behind the numbers, I don't know what does. This is certainly timely. December 6th is less than a week away. And of course, it was in 1989 when 14 women were murdered. And when we're talking about intimate partner violence at a broader level, of course, we're talking about gender-based violence. And as we approach the National Day for the remembrance but also action on violence against women, I think it's worth noting. I would conclude on a personal note that far too often violence is rooted in a power imbalance. It's rooted in the abuse of power. And as a straight white male of privilege, and not insignificant privilege, there's a big need for other men to acknowledge their privilege, understand their privilege, and never condone, participate, or remain silent in the face of violence, whether that is with a partner or other. And so I wear the white ribbon today, as I do most days. And for men, we have a role to play ourselves. So I will be supporting the recommendations. I look forward to seeing the details of the implementation plan as they progress. I want to thank our terrific staff for all the hard work that was put into this, and as well to our two deputants, both for raising the issue on a service delivery level, but also from the point of view of how do we protect, support, and empower people who work for the city every day, and how we as a city, and to Tim McGuire for raising the importance of noting that this isn't just about remembrance, it is about action, and we can do more as a city. Thank you.
Great, thank you very much, Councillor Cressy. Angela, to speak.
Thank you. I just have a question, and maybe a friendly amendment to Stacey's motion, but does it include the federal government? Maybe forwarding it to the Minister responsible for Status of Women and Aboriginal Affairs? Yeah, I don't know if that's...
For Aboriginal Affairs, I was referring to, the provincial level, but it probably should go to federal because the Ministry of Citizenship and Immigration is the federal level, as well as Justice Canada. So that would be a good amendment, yeah.
And just on, the note of Minister responsible for Status of Women as they deal a lot with violence against women there. Yeah.
That's it, Angela, in terms of... Okay, we're going to need a little bit of time. Do we need time? I just need Angela's. Oh, yes, it is. Actually, it is, yes.
Okay. We're okay. I could put Councillor Doucette.
Okay, so the way we're going to I'm suggesting we handle it is that we move the Medical Officer of Health's recommendations as amended in number, especially number 6, getting rid of relevant and making it agency boards and commissions, and move that as a piece. And then also move your motion, Councillor Doucette, as a piece as well. The whole thing as a piece, so that we're both on record as advocating for ourselves as a health unit, Board of Health, and that we're asking, the advocacy piece is asking our colleagues at City Council to do the same. Does that sound fair? Okay, so do we need to separate out anything here? Okay, so as a block, all in favor of the recommendations? Opposed, if any? That's carried. Thank you very much, everyone. I think we did Zahra proud this afternoon. The second item is Pharmacare, improving access to prescription medications. We have 4 deputants here. We do not have a presentation on this item, so I'll invite Dr. Danielle Raza, Dr. Joel Lechkin, Sean Mahar, and Karen Buck to come forward one at a time, starting with Dr. Danielle Raza. Nice to see you in this context.
Nice to see you, Joe. My name is Dr. Daniel Raza, and I'm a physician at St. Michael's Hospital, a lecturer in family medicine at the University of Toronto, and I also serve on the board of directors of Canadian Doctors for Medicare. I also want to take some time to acknowledge a number of medical students we have in the audience today who made the trip from the U of T chapter of Canadian Doctors for Medicare. Today, I'll be speaking in support of the recommendations made by the Medical Officer of Health in Toronto Public Health's report on Pharmacare, that the Board of Health urged the Government of Canada to work in collaboration with the provinces to develop and implement a national universal Pharmacare program. Now, many are surprised to hear this, but Canada is the only developed country with a universal healthcare system that does not include universal coverage for prescription drugs. It's something that I see every day I'm in clinic and has become so common that every time I welcome a new patient into my practice, I not only ask them about their family history, about their allergies, about what medications they're on, but I also ask them if they have insurance for prescription drugs. And I am constantly both disappointed and surprised by the number of patients who say no. Their answer matters because my patients without insurance are 4 times more likely to skip prescriptions because of cost than their neighbors sitting next to them in the waiting room. And it's not just my own experience or just that of my patients. There are nearly 8 million people in Canada without drug coverage. And even those with drug coverage are underinsured. The situation is so bad that 1 in 10 Canadians cannot afford to take the medications that their doctors prescribe. And it's not just an issue of gaps in care, it's also an issue of financial sustainability. Amongst the Organization for Economic Cooperation and Development, we spend the 2nd highest per capita in drug costs, eclipsed only by the United States. For medications like metformin that I use to treat all of my type 2 diabetics, we pay 5 times more per pill than a country like New Zealand. For citalopram, a common medication for depression, we pay 10 times more. And municipalities like Toronto across the country are on the hook for these costs, spending $500 million annually on drugs for employees through benefit plans. In fact, 12 municipalities across the country, including Vancouver and Hamilton, have recognized this problem and passed motions very similar to the one that I am speaking in support of today. And just last week, over 300 health policy experts and physicians, including 10 Order of Canada recipients, published an open letter in the Toronto Star calling on the Prime Minister to work towards a national, universal, and public drug plan. And here's the best part about making that change. A recent study published just this spring from the Canadian Medical Association Journal found that a universal public plan that pooled national purchasing power through bulk buying and used evidence-based decision-making to include only the most effective drugs would not only expand drug access to every Canadian in need, but reduce our total spending on prescription drugs. How? With just under $1 billion of public investment, spending by employers on private drug plans would be reduced by $8 billion, a boon for business and an economy looking for a competitive edge. In total, prescription drug costs would be reduced by approximately $7.3 billion. Now, I'm sure that everyone's lives here today would be much easier if every policy decision made, every vote on council floor, and every constituency meeting ended with an announcement that both expanded city services and also reduced cost. Well, today in healthcare, that is an opportunity that I'm proud to be advocating for, and one that I hope that not only the Board of Health chooses to support, but decides to forward as a motion to the floor of City Council. Thank you.
Thank you very much. Are there any questions? I have, oh, sorry, Councillor Cressy, go ahead first.
Thank you, Daniel. You mentioned 8 other municipalities. Do you know which ones those are? Could you provide a couple examples? You mentioned Vancouver. Who else?
So Vancouver, Hamilton, the City of Victoria, City of Cambridge in Ontario, Ajax, Durham Region, Inverness County, a smaller county out east. I believe there are others that I'm missing, but that's just a sampling of the list.
Thanks. And can you just clarify, I would ask staff, but you're also a doctor in the House, so I figure you can help answer the question for me. With the National Pharmacare Plan, would we require changes to the Canada Health Act and provincial agreement, or is this legislation that could simply be done at the federal level?
So that's really up for discussion. There's different ways that a plan like this could be implemented. At present, a number of public plans are administered by provinces. So if the federal government could choose, they could, when they return to the table to renegotiate a health accord, this could be rolled in as a part of a new health accord.
Okay, thanks.
Ashna, questions?
Hi, Dan. I had a specific question. I just wanted you to clarify what specific population groups would benefit from a Pharmacare plan, because the Ontario Drug Benefit Plan looks after people who are on government assistance and all of that. So I just wanted to clarify that.
Yeah. So as it stands, there are not many Ontarians. Well, there are a number of Ontarians that are covered by the public drug plan here, the Ontario Drug Benefit. But in order to qualify, you either have to be poor enough or you have to be old enough. If you're neither of those two categories, then people are largely dependent on drug insurance plans that are delivered through their employers. Now, the issue with this is it, of course, doesn't cover every Canadian, but even people who are insured by this are often underinsured. And not everyone, of course, with a job will have access to an employer-based drug plan. So, for example, just this spring, the Wellesley Institute released a report that looked at how coverage for employer-based drug plans is related to the type of job you have. And of course, we're hearing all the time about the rise of precarious work. So one of the findings that they reported is that if you're lucky to be wealthy and probably already healthy, earning more than $100,000 a year, there's a 94% chance that your job will already have a drug insurance plan. However, if you're one of the Torontonians earning less than $10,000 a year, only 17% of people from that group will have access to a drug plan. And that doesn't even begin the conversation around co-payments, deductibles, dispensing fees, and how that creates added barriers to care for people who are already low income.
Great, thank you. Could you go into a little bit more detail on where that savings is to be had for us as Canadians?
Yeah.
Is it really around the bulk purchase? Are we being frisked right now, frankly, by large drug manufacturers around some of the costs that we are currently paying?
So one of the models that advocates will often talk about for Canada to emulate is the New Zealand model. And New Zealand really has 3 core elements in their national drug plan. The first is evidence-based inclusion into their formulary or their national list of medications that they pay for. So we already do this for some of our public plans, where we'll only include new medications that are better than the ones that we already pay for. But private drug plans don't do that. Private drug plans will include every new medication on the market, regardless of whether they offer a therapeutic benefit or not. And that represents a huge, huge added cost. If we were to have a national formulary and a public plan that brought evidence-based decision-making to bear, we would save a substantial amount of money there. The other thing that they do in New Zealand is something called systemic tendering, where they'll use reference prices of similar classes in order to negotiate with drug companies. So for example, if a new medication is out to reduce a patient's heartburn, they'll look at other medications that are similar to that one and look at their prices in order to negotiate down with drug companies, which is something that we historically have not done in Canada. And the third thing they do is they bulk buy. And New Zealand does this as a small country of 4 million people. We have substantially more buying power and a better economy of scale than they do. And we can certainly realize substantial savings through that mechanism as well.
My second question is who loses if we do Pharmacare? Why haven't we done it up to now? What are the interests that are preventing us from doing this?
So at present, the people who are in the business of providing private drug plans are the insurance providers, and things like evidence-based formularies or tougher negotiations may also reduce some of the margins that some drug companies have as well. So there are certainly winners and losers in every public policy decision. This is one that would come at the benefit of so many patients in my practice, but patients who don't have access to medications across the country, and would be a big win for the financial sustainability of our healthcare system.
In the last question, somehow anticipating that someone's going to move a motion for this to go to council, is if council were to endorse this, would we see then, would a typical employer, a large employer like the City of Toronto, 50,000 plus employees that pays all kinds of health care costs, we can expect that cost to go way down as well, and therefore, frankly, be a strong savings for our own budget process.
Exactly. I mean, if this plan were to go through a national universal public drug program, it would essentially eliminate the costs that employers have to pay for private drug benefits for the employees. It would represent substantial savings for the City of Toronto.
You know, has any company ever quantified that? Large public sector employer?
Well, nationally, municipalities spend about $500 million on employer drug plans, but I don't know the specific details for the City of Toronto.
Okay, thank you very much. Appreciate your answers. Nobody else? Oh, sorry, one more. Trustee Glover.
This is not an area where I have any expertise, but I do remember a public debate around extending federal legislation to extend the patent period for drugs in the early 90s. And it was after that I first started hearing about people paying $5,000 a year or $20,000 a year for drugs. Are you familiar, so I've got two parts. Are you familiar with that legislation, and how does it fit into this conversation and the ability of the government to introduce a Pharmacare plan?
Yeah. I'm not familiar with that particular piece of legislation. But you're right, there's always issues around patents. And one of the particular issues I think that you've raised speaks to the need for us to apply the best available evidence for drugs that we pay for. There are lots of new drugs that come out on the market that are under patent. Some are good and some are not very good. And we should only be paying for the ones that will actually have a positive impact for our patients and that are better than the ones that we are already using. So an evidence-based formulary as a part of a national drug plan can go a long way in making sure that the medications we use are only the ones that are most appropriate.
Great, thank you.
Great, thank you very much. Very helpful comments. Our next deputant is Dr. Joel Lechkin, York University. Welcome.
Hi.
Joel.
Thanks very much for the opportunity to be here. So I not only teach health policy at York University, I'm also a practicing doctor. I work in emergency departments at the University Health Network. And I won't repeat most of the financial details that you just heard about. I'll just say a couple of quick things. So first of all, in the 50s, we decided we would have government-sponsored hospital insurance. In the 60s, we decided we would have government-sponsored insurance for doctors, but we neglected drug coverage. So what we've effectively done is we're imitating, when it comes to drug coverage, we're imitating what the United States does for its entire health system. So some of the money, about 38%, is paid for publicly, about 20% is paid for out of pocket, and the rest of it comes from private drug insurance plans. And that's essentially what the United States does. And in terms of overall health coverage, the United States is uniformly recognized as having about the worst system you could imagine. Costs go up as a result of it. People are left uninsured, or even if they have insurance, they're forced to pay deductibles. When it comes to Canada, if you look at the numbers, the people who are in the lowest 1/5 of the income group who do not have insurance, about 1/3 of them will not fill prescriptions because of economic reasons. So that's a lot of people who are out there, and those are some of the people that I see in the emergency department. We are usually reaching for supplies that we have on a daily basis to give to people who can't afford their medications, in the hopes that we can get them through a course of treatment. Having worked in both Australia and New Zealand, I can tell you that the system there is far superior. I did not have to worry when I wrote a prescription in those countries about whether or not people were going to be able to afford their medications, because I knew that they were going to be covered by the public drug plans in each of those countries. But beyond the issue of saving money and beyond the issue of making sure that everybody has insurance, there are other benefits that we can realize from a national Pharmacare plan. And one of those is helping both people and doctors make the right decisions about medications. And this goes to the issue of what is often termed skin in the game. The more that the public is paying for drugs, the more interest they have in making sure that drugs are used appropriately, because if they're not being used appropriately, that's wasted public money, and nobody likes to waste public money. So what's happened, for instance, in Australia, is where they have a national Pharmacare plan called the National Prescribing Service, they fund an organization called the National Prescribing Service, or Medicine-Wise, to the tune of about $35 million a year. And that organization is designed to encourage, to promote education amongst doctors and how to use and how to prescribe appropriately. And it's also designed to help patients take their medications properly. And they don't do this because, well, they may do it because they're nice people, the government, but they do it because they think they're going to save more money on prescription in terms of appropriate prescribing than they're spending on this organization. This organization is run, it's a arm's length from government, and it designs continuing medical education programs for doctors in a variety of ways, and it also funds patient education programs. And recent literature that's come out of Australia shows that in the case of medications for heart disease, those programs work. They improve the ability of doctors to prescribe appropriately. So I would urge this committee to pass the motion, send it on to City Council, because not only will it save money for save money in drug costs, make sure that everybody is covered, but it also has the strong potential of making sure that doctors like me prescribe appropriately, and people who are taking their medicines have the best evidence available.
Thank you very much. Questions? Seeing none, allow you to go back to your chair. Thank you very
All
much.
right, I have a copy of a report that was released in the summer. I don't know who.
Clerk will take it, and
Okay.
is it a long report?
It's about 23 pages. I don't know if that's long by your standards.
Twitter is sometimes long by our standards.
Nice, nice.
That's right. Yes, I'm not sure, are you going to distribute that?
Did you want copies right now? Could you-
Okay, yes, I'm really just thinking,
City clerk.
or file it with the city clerk? Okay, we'll either file it with the city clerk, and distribute it. Okay, great. Thank you. Okay, Sean Mahar, next speaker.
Hi, my name's Sean Maher. I am the Executive Director of the Social Planning Council for Toronto, and also a longtime active member of Canadian Doctors for Medicare. And I wanted to speak in strong support of this motion and also of the idea of moving it forward to Toronto City Council. As Dr. Raza mentioned, Toronto is the only country in the world with a national healthcare program that does not have a national pharmacare program. And that spells out into something that is a social disaster, a healthcare disaster, and a fiscal disaster. It's a disaster because Canada right now pays the second highest medication costs in the entire OECD. A drug like Lipitor costs $811 a year to prescribe to somebody in Canada, costs $15 a year in New Zealand. The generic version of that drug, a drug for which we spend literally billions of dollars a year in this country, the generic version is 10 times the price in Canada as it is in New Zealand, despite the fact that it's produced by a company here in Toronto. Councillor Mihevek suggested we might be getting fleeced by Big Pharma. I will leave it to him to judge, but those numbers pretty much speak for themselves. The fragmented purchasing power of 10 provinces, 3 territories, and dozens of individual private insurers guarantee that we can't negotiate on the same kind of basis as the government of New Zealand or the U.S. Veterans Administration, which also beats our drug prices 10 to 1 time and time again. This is a bad deal, and it's structured as a bad deal, and the result is that in the most recent studies, in fact, 1 in 4 Canadian households can't afford the drugs that their doctors prescribe. That would be 7 million Canadians for whom we are paying for them to see a doctor and then not making sure that they get the medications that will make them healthier. That is most relevant in particular places in the country, and Toronto is one of them. The people who tend to miss out on access to medications are low-income families that aren't on public benefits like OW and ODSP. The working poor are the ones who overwhelmingly lack access to medications. And here in the income disparity capital of Canada and the child poverty capital of Canada, that matters a lot. The other people who are most likely not to get access to the medications they need are precarious employees, people who work in the service industry. And here in the tourism capital of Canada, that also matters a lot. We fail to address these matters, even though, as Dr. Raza noticed, recent studies show that there is an enormous amount of money to be saved by a national pharmacare system. The study out of the University of British Columbia that he referenced showed that we could, just in the savings of bulk buying alone, deliver a national pharmacare program to everybody who needs it at no cost to the public sector, and at a significant savings to the private sector. It's also worth noting, as Dr. Lection noted, that there are a number of studies, including one from the New England Journal of Medicine and one done right here in Toronto by Irfan Dalla and Avi Denberg, that show that if we just give drugs to patients who are recent heart surgery, who have recently had heart surgery, the cost of giving the drugs is less than the cost of the complications, fixing the complications that result from not taking the drugs. So in fact, our healthcare system saves money, as well as our tax system saving money. So it's probably no wonder at all that the last poll of Canadians that asked how many people wanted a national pharmacare program came up at 91% in favor. because that savings is not only something that helps our healthcare system and helps our public sector, it helps our private sector enormously. The $8 billion that Dr. Raza mentioned that the private sector would save, they would save from money that they currently spend on private drug insurance programs. That not only makes our private sector more competitive. Charles Wagner, the former CEO of GM, used to argue that the healthcare costs in the United States added $1,500 to the sticker price of every car. Imagine what having a pharmacare system could do to our competitiveness, but also imagine what it could do for one of the corporations that spends a lot of money on pharmaceutical insurance, and that's our municipalities. Dr. Raza mentioned $500 million a year gets spent by municipalities in drug insurance. In Toronto, that's $43 million. That's how much we'd save, just this city alone, if we had a national pharmacare program. That's about enough to fund the entire tax increase for the coming year. We're talking about a substantial savings that we could be investing in things that are important to our city. That's why a dozen municipalities all across the country, representing more than 2 million Canadians, as well as the Northern Ontario Municipal Association and the Association of Municipalities of Ontario, have endorsed Pharmacare, and why it's now under debate at the Federation of Canadian Municipalities, because this matters. So we're encouraging you to forward this motion to Council, to adopt it here today, because as was mentioned earlier, this is one of the places where the good thing to do and the smart thing to do are the same thing.
Great, thank you very much. Questions? I appreciate your comments. Sean is... Councillor Cressy?
Did you say that 1 in 4 Canadians can't afford to take meds prescribed? Did I hear that? I've heard different numbers just in terms of...
The number's been growing in successive studies. 1 in 10 is the one that's most popularly recognized. That rose to 1 in 5 in a study about 5 years ago. A study came out this summer. 23% of Canadian families say they forgo medications that they need because of cost.
Thank you.
I have a quick question. That $43 million number, it's a number that I think Council will pay attention to be quite honest, and a very cost-conscious Council.
Yeah,
is that a studied number?
Yes, that's a number from a study done at the University of British Columbia. That's the same study that produced the $500 million number. $43 million for Toronto, $20 million for Calgary. Municipalities all across this country can upload a significant part of their costs to the provinces and the feds by encouraging them to complete the process of our public health care system by making sure that patients can take the drugs that their doctors prescribe.
Okay, thank you. Thank you very much, Sean. Last speaker is Karen Buck.
Whoops.
Okay. Karen.
Oh, it's caught on my own feet. Anyway. Well, I guess it continues where the teeth are not a part of health and the healthcare system. Page 6 of the background report says it all. Toronto Public Health works to reduce health inequities and to improve the health of the whole population through the promotion and protection of health and the prevention of illness. Dental caries is a disease. No medication for a disease that I know of should be administered through the public drinking water system without doctors controlling the dose and monitoring the outcome. I have been before this board hoping that someone on the board would be forward enough thinking or caring enough to start the conversation on an Ontario dental care program that does work to reduce health inequities and does improve the health of the whole population.
Karen, time out. The item before us is Pharmacare, improving access to prescription medications. It's not about...
It is about, because if you were to take dental caries...
It's not about, that's
if you,
actually...
just wait. If you were to take dental caries as a disease, and you were to be prescribed by a dentist for different treatments in the dental office, you would be under a type of Pharmacare program. And it would be doctor-controlled, and it would be doctor-monitored,
I think
which
it's a
it
big
needs to be.
stretch. I think it's a big
Well, I
stretch
don't
beyond
think
the-
it
I
is.
know, and it's, you know, it's kind of my call. So I'm going to ask you to stick to the topic that is before you here, prescription medications.
Okay, and I'm just going to, I'll say one more sentence. I have brought forward the concern from a team of researchers at St. Michael's Hospital who authored a recent study who stated that it is no longer acceptable to look at dental health separately from overall health. And there are dentists who do prescribe different kinds of medication in their practice that their patients would be getting. And I think it should be covered completely, just like Pharmacare should. Thank you.
Thank you very much. Questions? Okay. Okay, that takes care of our deputations. Are there any speakers to this item? Question, oh, sorry, yes, questions of staff. Questions of staff, Trustee Glover.
Okay, I'm just trying to work through this in my head. If you were to do, and this is the question to staff, and just I'm trying to clarify my own thinking. If you were to do a cost-benefit analysis of this, the benefit would be clearly for the drug companies that can charge much more in Canada than they can in these other countries. And the cost would be to taxpayers who are paying much higher. But there would also be other costs because there's the percentage, whatever it is, 10, 20% of people who are not taking the drugs. And I would assume that when they're not, and it's mentioned in the report to some degree, that there's complications in their treatment. Can you just comment on, am I correct in this cost, like, you know, back of the napkin cost-benefit analysis?
In general, yes, there would be costs associated with inadequate, inappropriate, or mistreatment, and those would be the costs of more severe disease later on.
Okay. Okay, that's all. I just wanted to bring that up. Thank you.
Okay, seeing no further questions, speakers? Oh, Ashna? Go ahead.
Sorry, I
I'll
just
start
stepped out there. Just another quick comment. Thank you very much to everybody who came to speak today. One of my areas of research is actually looking at what affects how people take their medication. And my focus has been across sort of lower middle income countries, but more recently comparing that data with North American data and Canadian data, I can tell you that for diabetes, high blood pressure, people with cholesterol problems, the rates of, I would say, poor medication adherence in some of the low middle income countries is about 54%. And it's almost exactly the same here. And that, which is surprising, very surprising to me. And when we look at why that is, the main predictor of poor medication adherence is cost. Again, something that surprised me, having come from the UK, where we did have a British national formulary. In fact, I used to carry the little book around in my pocket, arrived in Toronto and wasn't sure what I was going to do with it. It's now in the bin. But so it's just to reinforce the fact that this is an important part of care. As a physician, we're dealing with the complications of people not taking medication. And if cost is the reason for that, then we should think about how to address that.
Thank you very much. Other speakers? Councillor Cressy?
Thank you. I'll keep this very brief. First of all, I have a motion, if it can be put on the screen. This is that City Council urge the Government of Canada and that City Council support the action of the Board of Health. And it goes on. As we've heard today, 8 million Canadians without drug coverage. We've also heard that 1 in 10 Canadians who have drug coverage can't afford to pay for the medications that they're prescribed. And as we've heard again and again, Pharmacare, not only would it improve and increase the health of Canadians, it would, in fact, increase the economic viability of the healthcare system, and in doing so, decrease the cost of drugs. 12 municipalities have already passed it. I heard somebody say that represents 12 million Canadians. Well, if City Council endorses it, let's bump that number up to 16 million Canadians, and we're getting there. And it just seems to me, as it's been said, that here you have Canada is the only country in the world with a public health care system without a pharmacare system, and it's high time we changed that. And I think this would be a strong statement of support in that direction from the City of Toronto, certainly our Board of Health, and with thanks to our staff for helping get us here.
Thank you very much, and I assume you're moving the recommendations of the Medical Officer of Health as well?
I'll move those as well, thanks.
Great. Okay, any further speakers? Stacy.
I have a motion for recommendation 2. The recommendation is to add the Ontario College of Physicians and Surgeons and Canadian Society of Health Pharmacists. My reason for this is it already mentions in the report that 8% of Canadians are not using their prescription drugs within the last 12 months correctly, and I'm really concerned that this is going to increase because we have an aging population. So that's my main reason for the recommendation.
Can I ask you a question on that? Yeah. Are you aware, and if you're not, maybe the Medical Officer of Health, where the association, I'm not even sure their formal title of pharmacist is at with this issue?
I'm not sure where they are with this issue. I was doing some research, but just based on what they are, they're a voluntary organization of pharmacists committed to patient care through advancement of safe, effective medication use in hospitals in collaboration with healthcare sectors. So just based on what I've seen with the way they've been doing their work historically, it seems like they could benefit from looking at this report.
Do we know where they're at, Dr. McCune? They're governing bodies, or are they allies? Okay, not to worry. I'm sure the coalition will be able to brief me on that. Okay, so we have 3 sets of motions. Do we need to separate any of them out? Okay, so vote on them as a package. All in favor? Opposed? That carries. Thank you very much for your very helpful education here today to those who made a deputation. And to staff as well for a very good presentation. We're on to 8.3, developing the Toronto Indigenous Strategy. We have a short video, and then we have 2 speakers.
Just introduce it if you're okay.
Dr. McEwen to introduce.
Thanks very much, Mr. Chair, members of the board. The board will be aware of this initiative because it's included in our current strategic plan. We thought it would be good to give you an update on how it's going so far. The report does that. I just want to share a clip from a video that an independent filmmaker made of the launch event, which started the Toronto Indigenous Advisory Health Circle, so you can hear a little bit from the voices of some of the members of the circle.
Well, a circle, as I see it, is a living process.
The circle is made up of Aboriginal leaders, people with great experience, expertise, and commitment to the health and well-being of the Aboriginal community.
We have a really great dynamic group that really has a of the community, the Aboriginal Indigenous community in Toronto.
One of the things that is important about the Circle Initiative is that it incorporates traditions and beliefs and practices into the process that we are.
For me, in 50 years, I would like to see those kinds of relational ties to be strong for all people, strong and inclusive.
I envision a community where the Aboriginal people have health outcomes and health conditions that are at least as good as the mainstream population, if not better.
What I see this effort here going forward is really about not compiling a bunch of information. Rather, this has to be a living process. It has to carry on.
I must say, I'm really pleased to see our youth council involved. It's really an honor to have you here. Miigwech.
Thank you very much for the video. I was there. It was a very powerful inaugural event. We have two deputants on this matter. First is Todd Ross, Toronto and York Region Métis Council. Welcome.
Thank you.
I didn't know.
I used to sit in that chair. I was the chair of the Toronto Atmospheric Fund in the last term. So I first want to acknowledge that we're on the traditional territories of the Mississaugas of New Credit. I'd also like to acknowledge the Haudenosaunee and the Wendat people and all the First Peoples who were here and called this land home before. I'd like to introduce myself in a traditional way. Nin Wabanakwat Nadishnakas, Megizi Nin Dodam. I introduce myself as Wabanakwat and of the Eagle Clan. I'm also, my name is, as you mentioned, is Todd Ross. I'm chair of the Toronto and York Region Métis Council, which is the vice president role, and we represent Toronto and York Region. We'd like to thank and congratulate the Toronto Board of Health on considering a Toronto Indigenous health strategy. I'd also like to thank the staff of the Board of Health, as well as the Toronto Central LHIN and Anishinaabe Health for the work that's gone into this. And we celebrate it. The Toronto and York Region Métis Council is a chartered community council and forms part of the governing structure of the Métis Nation of Ontario. Our councillors are elected by Métis Nation citizens, and our council is the democratic representative of the citizens of the Métis Nation of Ontario who live within the geographic territory described in our community charter agreement. Our council is responsible for representing and furthering the interests of our community. Our strategic priorities focus on culture, sustainability, education, outreach, and health. The Council has a working group focused on addressing and improving the health needs of Métis people within our geographic territory. That includes building relationships with other organizations like Anishinaabe Health, Native Child and Family Services of Toronto, the Ontario Federation of Indian Friendship Centres, Two-Spirited People of the First Nations, and others, and connecting to the ongoing work of Health and Wellness Branch of the Métis Nation of Ontario. We're excited to learn of the ongoing work and proposal of the Toronto Indigenous Advisory Circle and would like to be involved going forward. Specifically, we have identified two councillors, our Senator Constance Simmons and our Women's Representative Lindsay Dupree, both of whom have extensive backgrounds in health-related fields and are interested in actively participating in the strategy or in the circle. The Council is also interested in actively participating in future consultations, and the Toronto and York Region Métis Council has confirmed with the Métis Nation of Ontario that they are interested in being consulted on future consultations of the provincial territorial organizations. Again, I'd just like to thank you for bringing it forward. I think this is a tremendous milestone in Toronto's history. And we're pleased to be here today. Megwech, Marcy, thank you.
Great, thank you very much for your comments. Your exhortation to be part of the circle, you're aware that it's not our circle.
We want to be part of the strategy. And would also welcome being part of the circle, which my understanding is the circle is both the Board of Health as well as the Toronto Central LHIN circle.
Okay. Well, I'll ask staff exactly how that whole thing is structured. But I certainly appreciate your presentation. Are there any other questions of the deputant? Okay, thank you very much. Appreciate your coming. Yeah. Karen Buck.
I think that this program could be the program where Toronto Public Health and the Board of Health actually take a stance to say that in trying to guide the work of both Toronto Public Health and the Toronto in a direction of a holistic and comprehensive Indigenous health strategy, that dental and oral health be a part of that health strategy, including other health issues. And I think that this is really very, very important, And I'm hoping that this will be perhaps a new beginning of including dental care within the framework of total health strategies in Toronto. Thank you.
Thank you very much, Karen. No comment, no questions? Okay, we'll take it into the board. Are there any questions of staff? My question would be to the Medical Officer of Health on exactly the relationship of the Métis communities or the council in particular with the circle that has been created and the strategy.
Well, the Circle's creation was supported by a partnership of Toronto Public Health, the Toronto Central LHIN, and Anishinaabe Health Toronto. Those were the original partners who created the Circle. The membership and mandate are really now in the hands of the Circle. I think, the Board of Health can't change the constituency or the membership or the mandate of the Circle. It's really, we talk about Aboriginal health in Aboriginal hands, those are the hands. But I think anyone who's interested in playing a role in the development of the strategy can approach the Circle and talk about membership or being consulted or contributing in some other way to the development of the strategy.
Okay, other questions, staff? Elisa?
I had a point before the presentation there. So does this mean, will you be bringing feedback back to the advisory council from the Board of Health meeting?
Well, the Circle is aware that the Board of Health was considering this report today, and anything that the board wishes to convey to the members of the Circle, I'd be happy to bring back.
Okay, so then I'll go forward with my question. So congratulations, I was glad to see this on the agenda. And so I recognize that there was a number of organizations that were met with, and the structure has memberships who represent themselves. However, the members, I asked the staff to forward me a list of members, which just made me think of something I had recently read on the Inuit National Day for Inuit. To my knowledge, none of these members are Inuit, and there are 1,300 Inuit in Toronto. So I was wondering, I recognize the nature of the development of the Circle and all of that, but just to bring that knowledge back, because I just recently heard of a group that was struck in Toronto because of the lack of services for Inuit in the city, the Inuit of Toronto, Inuit Katamavik. So just to bring that sort of feedback back to the Circle.
I'd be pleased to do that. I can confirm that the Circle has talked about and is aware of Inuit issues in Toronto. I think you're right. I don't think there's a person of Inuit identity on the Circle. The creation of it was done through a community consultation, and we've come up with a group of people with great expertise in terms of Indigenous health issues in Toronto. But there's always the need to consult and engage a wider community. It's a very diverse community, as we know.
Great. Are there any speakers to this? Okay, so the appropriate motion is just to receive for information. And let me just say, I did go to the kickoff, and it was just there was just such good, strong energy in the room, and it really made me proud to be a part of the health unit here at the city. That we were actively engaged, noting that this is an area where we need to devote a lot of energy and attention, Indigenous, urban health, and seeing that we're part of it is just a wonderful thing, I think, for us as a city and as a health unit. So, motion to receive the report. All in favor, opposed, if any, that's carried. We're on to 8.5, which is the update on extreme heat and maximum indoor temperature standard for multi-unit residential buildings. We have two deputants here. One is Jacqueline Wilson and Daniel Cairns-Nadelsky from the Canadian Environmental Law Association, followed by Daryl Chong, President and Chief Executive Officer of the Greater Toronto Apartment Association. Jacqueline Wilson and Daniel. Welcome.
Wilson. I'm a lawyer at the Canadian Environmental Law Association, and I'm here with my colleague Daniel Karens-Nadelsky, who's a student at CELA. We're here to support the Medical Officer of Health's recommendation to explore the feasibility of implementing a maximum indoor temperature standard. I've handed up written submissions, which will provide more details than I can provide in this oral presentation. But in this oral presentation, I'd like to highlight a few points that are written there for you, including the legal authority for a municipal bylaw on this issue, to give you some information on both the City of Toronto Act and the Building Code Act as sources of authority for this type of bylaw, and to look briefly at the law on conflict between federal and provincial legislation and municipal bylaws on issues of environmental health. Paragraph 8, sub 2, sub 6 of the City of Toronto Act gives broad scope to the city to enact bylaws respecting health, safety, and well-being of persons. Another provision of that act, subsection 6.1, directs that the city's powers are to be interpreted broadly. The case law also supports a broad interpretation of municipal powers. I'll reference two decisions. The first is the Hudson case. It's a Supreme Court of Canada decision from 2001 that upheld the municipality of Hudson's authority to enact a pesticides bylaw. The court's reasoning was that if the true purpose of the bylaw is to further the goal of public health and to address the immediate interests of the community, that municipal authority was there for that type of bylaw. The second case looked at a similar bylaw by the City of Toronto in 2005, at that time under the Municipal Act 2001, for a pesticides bylaw by the City of Toronto. That bylaw was also upheld, and the Court of Appeal asked for municipal authority to be interpreted broadly and generously and of interest to us here unless there was an express direction to the contrary in the enabling legislation. That's the City of Toronto Act authority. The other source of authority is subsection 15.13 of the Building Code Act, which allows the city to prescribe standards for the maintenance and occupancy of property. It was used to enact the bylaw addressing maximum temperatures in units that have air conditioning units, and it could similarly be used for a bylaw addressing maximum indoor temperatures for units without those air conditioning units. In terms of law on conflict between provincial legislation and municipal bylaws, there currently is no law addressing this issue in particular. But even if there was, the City of Toronto Act codifies the case law on conflict. And that case law says that there's a wide scope for municipal bylaws, as long as it's not impossible to comply with any future federal or provincial legislation, or the bylaw doesn't frustrate the purpose of those future laws, municipal authority should be upheld. And on that point, we disagree with one of Toronto Public Health's observations in their report, Protecting Vulnerable People from Health Impacts of Extreme Heat from 2011, that Section 216 of the Residential Tenancies Act will restrict Toronto's bylaw-making authority. Section 216 deals with and gives municipalities power to enact bylaws on vital services in rental units. But even if a bylaw addressing maximum indoor temperatures falls outside that category, that provision doesn't restrict Toronto's authority on other issues. And it's our position that that analysis is at odds with both the case law and the City of Toronto Act that call for a broad, purposive interpretation of a municipal authority in this type of area. I'd like to close by urging the Board of Health to adopt the medical officer's recommendation and to move forward on addressing the clear inequity that exists at the moment where there's a bylaw to address maximum temperatures for units with air conditioning, but there isn't one for apartments without, when it's quite clear through the many Toronto Public Health reports that people living in those units without air conditioning are much more vulnerable to extreme heat. Thank you.
Thank you very much. Are there any questions from the Board of Health? Seeing none, thank you very much.
Thank you very much.
Our second speaker is Daryl Chong.
Good afternoon, thank you. Excuse me. So I appeared before this committee in June of 2015 and raised some concerns. I've reviewed this updated report, and I have a few more concerns that I'd like to raise with you. The first one is the recommendation from staff is to explore the feasibility of implementing a health-based maximum indoor temperature standard of 26 degrees in apartment buildings. One thing is, this is a very low threshold. 26 degrees, you know, I'm 49 years old. I was in that area between Celsius and Fahrenheit when I was an elementary kid. So I did a Google search, and that's 78.8. And I'm not sure if that means anything to the younger people here that, you know, do centigrade. But to me, that's a very comfortable temperature. To me, that seems to be a very low threshold. But the report indicates that that's almost an already decided standard. In the recommendations, it's all about 26 degrees Celsius. So not sure where that came from. The report cites the Chicago heat wave from 20 years ago. In July of 1995, Chicago's temperature hit 41 degrees, and it sustained high temperatures over a 4-day period. They weren't always 41, that was one of the maximums, but that was the range about which this stuff happened. The Board of Health report cites a New England Journal of Medicine report, and in that same report, they recommend that provision of air conditioning, and I'll quote, in the immediate neighborhood or providing readily accessible transportation to public cooling centers could help to reduce excessive mortality during hot weather. Right, so that's the same report from the same study. Almost all the reports that I've read agree with Eric Klinenberg's, whose post-mortem book, Heat Wave, a social autopsy of disaster in Chicago, assessed the tragedy as the literal and social isolation of seniors, the institutional abandonment of poor neighborhoods, and the retrenchment of public assistance programs contributed to the high fatality rates. So Chicago is not Toronto, thank God. We're not Chicago, I mean. There are lots of neighborhoods in Chicago, and they attribute a lot of the deaths to people that left their windows sealed tight because they were afraid of crime. So they were suffocating in their own units because of other societal issues. Right. Mechanical air conditioning is probably not the solution. Urban heat extremes are the result of two things: urban heat island effect and global greenhouse effect. And the irony here is waste heat, which is expelled hot air to cool the interiors of buildings, is generated by air conditioning, as well as pollutants are used to create air conditioning. Both contribute to the urban heat island effect and global greenhouse gases. Increasing the amount of waste heat from air conditioning reduces the potential for natural cooling through passive architectural strategies, shading and things like that. In 2015, an author named Larissa Larson wrote, "Another negative consequence of our increasing reliance on mechanical cooling is the widespread potential for a heat emergency, given the potential for the electrical grid to fail under stress as it did in 2003, in August." And everyone remembers that blackout. They've documented an increasing number of brownouts and blackouts over the past decade in the US, in part due to higher temperatures, and in part that was because of more air conditioning. The same report recommends some strategies, and these strategies are to reduce the elevated urban temperatures, largely focused around mitigating the urban heat island effect. And they include using cool pavements, relying on cool roofs, increased vegetation, and especially this one, reducing waste heat, which is largely caused by air conditioning, mechanical air conditioning. So to go back to my deputation several months ago, just to say, in most apartment buildings, residents are allowed to safely install and use window air conditioning units. They've always been allowed this for decades and decades since the window units were invented. However, a majority of Toronto's residents choose not to. In your previous report in July, the Board of Health summarized the Toronto Public Health and Tower Renewal Cool Room Pilot Study from 2010, where 59% of the residents in the building did not have air-conditioned window units. So they installed a cooling room on site, and then they went and asked people why they weren't using it, because apparently no one came to the room. And they said there's nothing to do there. I mean, it was air-conditioned, but they said they preferred going to the mall, going outside, sitting in shade, and doing other things. So again, most apartment residents in Toronto have chosen not to install air-conditioned units when they're allowed to do so if they wish. And in this pilot, most didn't even utilize the cool room that was created on site. So this leads to the mandatory mechanical air conditioning for temperatures above 26 degrees Fahrenheit or 26 Celsius or 78.8 Fahrenheit in more than 300,000 purpose-built apartment units in Toronto would have a profound negative environmental impact and consequences, severely strain the electrical system both in each building and across the city. So respectfully, I think this matter should be left as is, and that is in the hands of individual residents to choose to do this or not. And the city should focus on some other mitigation strategies. Sorry, it's all listed in my letter. Thank you.
Great. Thank you very much, Daryl. Sorry it was getting to...
Understand.
Yeah. Questions? Councillor Cressy.
Thank you. So, Daryl, can you represent the Greater Toronto Apartment Association?
That's us.
And so can you explain just for a minute what the association is?
Yeah, we're an association of privately owned apartment buildings. These are the purpose-built rental buildings, so we don't represent investors of individual condo units or somebody that has a basement apartment or a duplex. Purpose-built rental is 7 or more units in one address.
So do you represent the owners of the buildings or the residents there?
No, the owners and property managers.
Okay, the owners and property managers.
Yes.
So you mentioned that the residents chose not to install air conditioners. Why do you think they have chosen not to install air conditioners?
I've been to many units, and I have friends that live in a lot of these units. These units are in the mid-60s and 1970s, we produced 14,000 units a year of new stock. So 140,000 units of purpose-built rental was built between 65 and 74, and the units are concrete and huge, and they have these great windows, which are kind of restricted from opening, but a lot of them also have balconies. But the air circulation is fabulous in these old units, and they're concrete with high ceilings. So they're actually quite cool.
So they've chosen not to install them because you're saying that they're designed and already cool?
No, I think the people that I've spoken to just have chosen not to install them because they say they don't need them. There could be a couple days a year that might be useful, but
So
typically...
If the people have chosen not to install them because they don't need them as opposed to they can't afford them, is that because the temperature in those units is comfortable? And if so, can you give me what is the average temperature during the summer months in the units that you represent?
I don't know. I did ask the Board of Health if they had a survey of temperature readings from the past summer previous, and they haven't done so.
I guess I would just surmise that if people were comfortable in these purpose-built rental units, then we wouldn't need to bring forward a threshold to make it more comfortable. But regardless, you said you were questioning our threshold of 26 degrees Celsius. So what is a healthy threshold from the point of view of your association?
I don't think the association is medically based. I don't think we would be able to give you a biological threshold.
So the association is not able to give me a threshold that would be healthy, but you're able to tell me that the threshold we're proposing is not healthy?
Well, what I've read in some of the reports that were cited in this Board of Health reports is some reports say 34 degrees is a decent threshold.
Sorry, which report says 34 degrees?
I'll have to find it and give it to you, but
So the reports that I have seen, are you aware that the Canadian Standards Association that governs office buildings has recommended under 26 degrees? Are you aware of that?
Yeah, I've read that. In an office building, you're typically wearing a suit, and I know there's ongoing debate between gender differences where men wear wool suits and women don't wear wool suits, and they're always cold. So we read about that all the time. I'm familiar with that.
So you're aware that the Canadian Standards Association that governs office buildings has recommended below 26 degrees?
I've read that, yes.
Okay. Are you aware that the World Health Organization has recommended that indoor temperatures should be 18 to 24 degrees?
I did see that report, and so, using that logic, why is our minimum set at 21 when 18 might be a better minimum?
So I guess my final question would be, given the research that is out there and does exist in office buildings and others, Why would your association not take the position of coming up with a healthy threshold as opposed to just opposing our proposal for a healthy threshold?
We haven't been asked to, but if you're asking, then I suppose we could do that.
Well, I would say if you are truly interested in representing the residents of your buildings and not just the owners who are making money off them, then you should consider doing that.
Well, I mean, my point is the residents have always had the opportunity to do this if they wanted, and most of them haven't. 2/3 of them choose not to.
Choose not to or afford not to. Have you ever asked them?
Well, the ones that I speak to can afford to, they choose not to. I obviously clearly haven't spoken to everyone.
Okay, thank you.
Have you ever done a survey of the residents in your buildings to ask them if they can afford air conditioners since they choose not to?
We have not.
Thank you.
Okay, Councillor Doucette. Okay. Any other questions? Yes, Councillor Burnside.
Sorry, I wasn't privy to the WHO report that is advising indoor temperatures of 18 to 24. The data I have says there's minimal risk to health. Does the report actually say advise 18 to 24?
No, you're probably right. I mean, I don't remember everything that I read, but those numbers ring a bell.
Okay, so just to clarify, they didn't actually suggest 18 to 24. They just said there's minimal health risk when you're in that range. Okay, thank you. If we were to mandate, and I don't even know if we could, but if we were to mandate air conditioning in units, would you not just pass that cost on or try to?
Well, I mean, the difficulty is the buildings largely are without any ductwork. There's no way to put any sort of central air conditioning into an old concrete building that lacks ducts. I guess the only solution would be window units, which are terrible environmentally, and they're huge energy hogs. So passing through the cost, yes.
Thank you.
Any further questions? Seeing none, thank you very much, Daryl. We appreciate your comments.
Thank you.
We'll now take it into the board and ask questions of staff. Councillor Doucette.
Thank you very much, and thank you very much, staff, for another very good report. Why did we come up with 26 degrees?
Well, we were asked to look at the potential for a maximum indoor temperature standard, and we looked at all of the science that we could find, as well as policies that other jurisdictions had undertaken. And 26, there is evidence that temperatures above 26 is where you begin to see a health impact, a negative health impact. There's also evidence that other jurisdictions that have looked at this have picked 26. And it happens to align with some other things too. It aligns with existing city requirements for buildings that do have air conditioning are required by bylaw to maintain the temperature below 26. So we saw 26 kept coming up. The science that does exist seemed to support it, and other jurisdictions have tended to use that temperature. Now, I think there's, would we like to have more data and more evidence? Of course. But based on what we see in the science, 26 is the temperature that makes the most sense.
So you're saying that 26 didn't just come out of the air. You looked at data, you looked at medical effects on people, and that's how we've come up with that number.
Yeah, no, and the report outlines the rationale for it.
Moving forward, we had 20 days per year when outdoor temperatures exceed, or approximately 20 days when outdoor temperatures exceed 30 degrees. Now, on all the reports I've read, and being on Parks and Environment, I understand that in the next 10, 20, 30 years, we're going to be having more days of extreme heat. Is that what you've been finding? Is that correct?
Yes, that's correct. Studies that we've done here in Toronto, as well as in other parts of Canada, suggest that as global climate change proceeds, we'll see an increased number of days of extreme heat, however that is defined.
I'm not sure if you can answer this one or not. I used to be in property management. Are all residential rental buildings, are residents all allowed to install window air conditioners?
I think that varies. That's not really our area of expertise, which is why we've built in, if the board accepts this basis for trying to ensure reduction in the risk to people who live in multi-unit dwellings, then we would be looking through a technical advisory committee that looks at the feasibility of different approaches to trying to keep temperature within that range, as well as an external sort of advisory committee of stakeholders who will include organizations like that represented by the last deputant to make sure that we're hearing from them as well in designing an approach.
My last question, because I could go on and on for far more than my 5 minutes on this topic. On page 6, we're talking about people sleeping. Well, before I had air conditioning and my house would heat up, I found it very difficult to sleep at night. And when I don't sleep at night, any councillor who knows me knows I can get really crabby and cranky. It's miserable. So just bringing up here again, I actually think 26 is far too high to be able to sleep. But I know it's in the report, but what happens to people when they don't get enough sleep on their health side of things?
Well, adequate sleep is an important prerequisite for good health generally. There are a number of different consequences, health consequences for people who have some sort of sleep impairment. I think we understand more about that now than we did a generation ago.
Thank you very much. I'll leave it at that.
Thank you. Councillor Burnside, questions?
Thank you. I don't want to presuppose the strategies, but would air conditioning be one of them?
I think that's one of them, yes. There's a couple of others that are mentioned in the report. There are cooling rooms. There are only 2 or 3 that are kind of laid out here because we accept the possibility that others may come up through the process.
And then would you be looking at the greenhouse effect of air conditioning as well? Because I know that's a concern, a larger concern of yours in past discussions.
Well, it is a concern, and it's a bit circular because, global climate change increases the risk for indoor temperature harm as well, so they're not unrelated.
So, but will that be looked at? Sorry, will that be looked at as part of, because it's sort of weighing one against the other, to your point, right?
Yes,
will that be looked at as part of the strategy moving forward?
Yes, I anticipate the consequences of the different options would be looked at.
Okay, thank you. Thank you.
Any other questions? I have some. We have literally hundreds of walk-ups, 4-story, 3-story walk-ups in the City of Toronto, built while either in the post-World War II era or, frankly, I think even in the pre-World War II era. Would we be looking to find a way to, let's say, deal with those kinds of properties in a different way than, say, buildings where there are ducts and that would be more amenable to everything from air conditioning even to a cool roof?
I think all of the variations in building stock are part of the challenge, and there may indeed be different solutions or different approaches for different types of buildings. That's what we would hope to explore through the process that I just described. This report really focuses on, is there evidence for a temperature which would be the focus of those kinds of efforts? And I think we did find sufficient evidence to identify a temperature. Now we have to look at how do you achieve that temperature from a health protection point of view.
Do you think there might be some kind of grandfathering provision, or is that off the table?
I wouldn't want to speculate at this stage of the process about the details of approaches that might be used. I think clearly there are lots of challenges which we've outlined in previous reports and which the board has heard from stakeholders to some of the options. Just mandating blanket central air conditioning obviously has got a lot of consequences to it. These are the challenges that we'll be exploring through the process going forward.
Great. Okay, thank you. Okay, any other questions? Okay, to speak, Councillor Doucette.
Thank you very much. I want to start, thank staff for this report. To me, 26 is hot. Okay, I come from England, but 26 is hot. And if you don't have air conditioning and the temperature of your house rises and rises and you don't have a way to let air flow through, you need to have some way of cooling it. A lot of residents in my ward can't afford an air conditioning unit. And if they do get the air conditioning unit and they're paying hydro, they can't afford to pay the hydro to have the air conditioning unit running. So I think it does go back on the landlord who owns a building to, in some shape or form, help keep that building cool in the hot summers. We are getting hotter days. We're getting more consecutive days of high extreme temperatures, and it's going to be getting hotter. So we've got to look at something. I think this is a good report. We've got to put some guideline in place, some temperature in place, because otherwise we do have a lot of residents who will call our office and say, what's the temperature? You know, we know that they have to have the heat on so many, at certain temperatures during certain months and certain dates. But what about the high end? And we say right now, there is no high end. Also in the report, it points out that some of the high-rise buildings can only open their windows a certain amount for safety reasons. We have a lot of children living in our high-rise buildings, and you don't want them just to open the windows wide because we're going to have tragic accidents. So there's a lot going into this. I appreciate it's not going to be, one size fits all different units. We got, 4-story, we got, well, in my ward, you've got 31-story. I know in other areas we have much bigger buildings. The older buildings are going to be our hard ones. I appreciate that. But I still feel it's the owner of the building's responsibility to maintain a healthy atmosphere, healthy temperatures, whether it's the high or the low, for the residents paying rent to live in that building. I would love to see more white roofs, green roofs, more trees planted, more other ideas so that the heat doesn't actually build up in those buildings. I'd like to see some more tower renewal of the old buildings to help insulate them, keep them warm in the winter and cool in the summer. That keeps the costs down for the owner, which a lot of them, that's their main bottom line. So I think this report is a good start. I think I now understand why we chose the 26 degrees. We don't normally, and our staff don't normally just pull numbers out of the air. In fact, I don't think they ever pull numbers out of the air. I should emphasize that. Everything is done with research.
It's not hot air.
It's not hot air either, no, exactly. Everything is done with research, and everything is looking at what other areas have done as well. So thank you very much. You got my full support on this, and I think you'll probably have most people's full support, so thank you.
I assume you've moved the recommendation.
I, of course, am moving the recommendations. I forgot to mention that at the beginning. Thank you.
Okay, thank you. Councillor Cressy to speak.
Yeah, I'm not going to repeat too much of what Councillor Doucette just said. 26 degrees is hot. It is very hot. If you can afford to sleep in a place that is less than 26 degrees, you do. And I think we all know that anecdotally and intuitively. It also, above 26 degrees, as the research, the conclusive research shows us, it is more harmful than less. The WHO talks about there is minimal risk between 18 to 24. The Canadian Standards Association that governs office buildings sets a height at 26 degrees. German research has talked about 16 to 26 degrees for lowest risk. And the UK National Health Service has said anything above 25 degrees is associated with increased health risk. That's the research. Now, I recognize that the solution is a complex one, because the solution comes with costs as it relates to capital as well as ongoing maintenance user. It also relates to, as the solution is, to the responsibility to implement these measures and the fixes. That's a challenge. And of course, there is the issue, depending on what the solution is, of greenhouse gas emissions. So it's not to say that the solution isn't complex, but the recommendation here today is to recognize the standard by which we, as the Board of Health, put down our mandate to ensure health, and then the recommendation is for us to work with municipal licensing and standards and other stakeholders to develop that complex solution. I don't see how, as a Board of Health, we would see anything wrong with that. I will say to the representative who came here today and was here in June from the Greater Toronto Apartment Association that the presentation I heard today was the exact same presentation I heard 6 months ago, and nothing has changed since then in terms of proposals, in terms of how we address the risk, or any additional research as to what the actual tenants are experiencing. And so my suggestion would be, just like the association that looks at office buildings, that the association work with us to look at the complex solutions, because there are problems, and to assume that it's simply a choice of residents to live in above 26 degrees as opposed to a problem that requires our addressing it is not the answer. And if when we come back with solutions in 8 months, and if the association shows up again and says there's not a problem, well, I'm not even going to bother to answer questions. I'm going to laugh them off the stage.
Elisa, to speak.
Just a short one, and it's from personal history. I won't repeat the other comments that were made, but in terms of safety, actually, as a renter, I one summer had the responsibility passed on to me from the landlord to install my own window air conditioner, to which I always remember now in the installation alone. It flung out the window right into the window below, and I always think, oh my God, what if someone was standing there? Nobody was standing there, but there's an element of safety in sort of these recommendations that, you know, there are those little things, right? One little person putting in an air conditioner into the next window, and that could happen at many other situations as well.
Thank you. Stacy, and then John.
I just have a question. Some time ago, and you guys might remember this, remember there was those retrofit programs to make homes more energy efficient? So I'm just wondering, is there a way for the province to better get involved and have something similar, especially for older homes, as it pertains to the cost of air conditions?
Thank you. Councillor Burnside.
Well, I always listen carefully to Councillor Cressy, and because I don't always agree with him, but he does make a lot of sense, and he's well researched. So I will give you that, and I do agree with most of what you say, actually. But there are a couple of points I would like to make. When Mr. Chong said it's a choice, and Councillor Cressy took exception to it, I get where you're coming from. The reality is, I believe it is a choice, and the reason they choose it is because they can't afford it, right? So I think we're all saying the same thing, we're just spinning it a bit. But that being said, I don't think there's ever a problem getting more information and learning about it and see if there are strategies, and you raised some of the issues. However, I will sort of say this, that at the end of the day, the reason we have such old stock is because it's not the most profitable business in the world. And it's questionable whether we're going to say that landlords need to bear that responsibility when hydro's 5 cents a kilowatt hour. It's just not going to happen. That cost is going to be borne by the residents. Maybe it should be. I'm not disputing that. I'm just saying that is the reality, and we should be ready for that too. Thank you.
I agree with Councillor Burnside.
Okay. Do you want a second round? Okay, thank you. Thank you, everyone. So we have 2 motions. You need them put up? We ready to vote? Councillor Doucette, yes, she's moving the staff recommendations. Okay, all in favor? Opposed, if any? That's carried unanimously. Okay, thank you very much. Thanks to the deputants on this matter. We have one more matter with a public deputation, and that is number 9, which is the 9-month operating budget variance. And we have Tim McGuire. I don't see him here. Has he gone? Okay, thank you. We'll look forward to receiving it. Are there any speakers to the 9-month variance report? The recommendation here by staff is that it be received. Motion to receive by Councillor Doucette. Seeing no opposition, all in favor? Opposed, if any? That's carried. So we have one item, really 2 items, but under one item. I think we're going to do them as a package. The presentation it's a package presentation. So we're doing number 10 and 11 at the same time. There are no deputations, but it is our formal submission to the city, or the latest submission to the city around the operating budget request to City of Toronto's Budget Committee. Dr. McEwen.
Thanks very much, Mr. Chair. Yes, this is, although some months ago we submitted a preliminary budget that has been working its way through the administrative process at the city, this is the board's opportunity to officially request its budget for 2016, both operating and capital. Now, people often tell me that our budget is quite complicated, and to the extent that that's true, it's because we have different funding models for different parts of it, all determined by the province. So I'll do my best to make it simple and give you an idea of where the staff recommend that the board send our budget this year. So my presentation includes an overview of the divisional budget and then separate sections on the operating and capital budget. So in dealing with the city, we're required to have a map of our programs and services, and we structure the map in such a way that it aligns with the provincial Ontario Public Health Standards, so that we are using similar definitions for both the provincial and the municipal budget. I'm going to break down our budget. The simplest way to understand it is to look at it as three different budgets based on the funding source. So about a quarter of the gross budget is 100% provincially funded. These are programs which are determined by the province, entirely funded by them. They're funded by either the Ministry of Health and Long-Term Care or the Ministry of Children and Youth Services. Just note that the Ministry of Children and Youth Services budgets are on a March 31st fiscal year end. So that is important when you're looking at variance reports. When we get close to the end of the year, it's the end of the year for most of our programs, but not for all of them. The main challenge with this part of our budget is that the province has not provided increases for a number of years to coincide with the increased cost in delivering services. And that flatlining means that we're managing inflation in our costs, both staff compensation costs as well as non-staff costs, within a fixed budget. And we typically do that by finding efficiencies first, and where we run out of efficiencies, we actually reduce staff and service levels. So in these programs, our staffing and service levels have been gradually falling over the past number of years to coincide with the budget having been flatlined. And the board has, on a number of occasions in recent years, advocated to the provincial government to increase funding to reflect increased basic inflationary costs. So that's the 100% provincial part of the budget. There is also a small part, about 7% of our budget, which is 100% municipally funded. It's really two programs, both of which the board's very familiar with, the Student Nutrition Program and the Seniors Dental Program. The challenges are somewhat different for each one of them. Student nutrition, as you know, we've put in place a plan which the board has adopted to grow that program over time to better meet the needs in the community. So it's a challenge to ask City Council every year for that increase. When it comes to the Seniors Dental Program, that budget, again, has not been increasing, and it continues to be a program that's responding to a high need in the community, so we have long wait lists for our clinics. The number of seniors, low-income seniors who do not have access to dental care is sufficient that people are willing to wait a long time to get services. The third part of the budget, and the bulk of it really, about 70% of the gross budget, is composed of cost-shared programs. These are programs where the province pays 75%, the city pays 25%, and both funders must come to the table for us to spend the money. If we don't get either portion, we can't spend the portion we've got. The challenges in this area really have been trying to maximize provincial revenue, take advantage of all of the money that the province puts on the table every year. And often that is at odds with the city's budget direction. So for example, for 2016, the guideline that we were given by the city manager was to reduce our budget by 1% in comparison with 2015. The province, on the other hand, was offering an increase. So we often have this conflict. And I'll just show you on the next slide how that has gone over the past several years. The first column on the slide reflects the province's policy decision about its public health budget for all of the boards of health. So you can see that typically the province was willing to approve an increase of between 2 and 3%. Started off being 3% a few years ago. The last several years it's been 2%. So you see this conflict between the city saying reduce by 1%, and the province saying we'll approve a budget of increasing by 1%. In each of those situations, the board, through its budget committee, has directed me to try and maximize the provincial revenue, which usually means we're out of sync with the city manager's direction for municipal budgets. You can see in the second column under provincial average, this was what actually was provided to boards of health on average across the province. And you can see in the final column the contrast between what the city asked for, or what the city asked us to do, and what we actually got. And cumulatively, we were leaving a lot of money on the table. There's only one year, 2013, in which we were able to ask for and receive a budget which was the maximum of what the province was willing to give us. The rest of the years, we basically left money on the table, which the province presumably gave to other boards of health across the province, because they asked for it. 2015, a unique situation occurred. Typically, and this, I've briefed the budget committee on this, but typically the province responds to an ask from the Board of Health, in this case from the city. Whatever City Council approves, the province decides whether to cost share or not. Starting in 2015, the province had developed a formula to equitably allocate its envelope of public health budget across the 36 boards of health. When it applied the formula, it found that some boards of health were already receiving a budget higher than the formula predicted, and some boards of health were receiving a budget lower than the formula predicted. There were 8 boards of health that were judged to be underfunded, of which Toronto was one. So they actually took the 2% growth, the envelope that they had for the entire public health sector, and gave it all to just those 8 health units, just those 8 boards of health, regardless of what they'd asked for. So in 2015, we asked for, and City Council approved, a 1.3% increase in our budget, and the province approved 2.6%. Now, as I said before, because you need both parts of the cost-shared budget to spend it, we couldn't actually spend the extra money that we were given in 2015 as part of the cost-shared budget. We were successful in requesting the province to allow us to use a portion of it as 100% one-time provincial funding in some areas of need, particularly, the largest one was in response to the increased requirements for the school immunization program. So we weren't able to use it in the way the province approved. However, that does become our base budget for 2016. So in effect, the province has pre-approved a portion of its contribution to a 2016 budget. So I'll pause for questions at the end of the operating budget. We are urged every year by the city to find efficiencies within our budget, and we try diligently to do that. I'll just give you a bit of a history. Between 2011 and 2015, we absorbed inflationary increases equal to more than $900,000. That is, we did not increase budgets despite the fact our costs were going up, which is an efficiency. Every year, we do a careful review of our budget on a line-by-line basis to identify areas where we may be able to reduce, and we've done that to the tune of about $2 million between 2011 and 2015. And we had a particularly significant efficiency in 2012 when City Council asked all divisions, agencies, boards, and commissions to reduce their budgets by 10%, which we did. That involved a reduction in our staffing of 58 FTEs, and saved $7.5 million, which is a combination of payroll costs and non-payroll costs. It was achieved through a mixture of methods. There was, for those who weren't here, there was some use of technology, there was some realignment of professional staff, there was some uploading of costs to the province. A variety of different strategies were used in order to reduce our budget by that amount. So going into the 2016 budget, we already have a record of having found significant efficiencies in the budget. So the actual request that we're recommending to the board, to recommend to council, looks like this in terms of its services. The allocation of the 2016 operating budget to the different services in our program map is on the left. The funding sources is on the right. So for example, the 73% in, I guess it's brown on your screen, that comes from the province is a mix of 100% provincial and the 75% part of cost shared. So it just gives you a sense of where it comes from. It happens to come out close to 75-25. Building the 2016 budget, this is a graph which summarizes the cost of our current service levels. This is before any enhancements. You can see that this is including absorbing some things. The base budget request is basically an increase of 0.3%, which is much less than the true inflationary cost of delivering our current services, but that's what we've come to. We've added in some efficiencies that we were able to find this year of about 0.25%. The final result is almost flatline, 0.05% higher than 2015 to deliver the same level of services that we delivered last year. Just so you know, the efficiencies that we found this year, we found an opportunity to reduce a contribution to a reserve fund for information technology. We were able to transfer a program which started in 2015, an enhancement, the mobile good food market enhancement, from 100% municipally funded to cost shared. So we basically shifted those costs to the province because it falls within the Ontario Public Health Standards. And we found some additional efficiencies by going through line by line in our non-payroll expenditures. So that's our starting point before we think about any change in service levels, is roughly where we were in 2015. There were four actually areas of service enhancement, some of which will be very familiar to the board. The first is year 2 of a phased implementation of the day nursery immunization program. Year 1 was implemented for 2015. The second is an increase in a 5-year enhancement of the Toronto Urban Health Fund, which was directed by the board. So this is year 2, about $150,000, growing that program. The third reflects our experience with salary gapping over the past year. As you know from previous reports, we've had a history of high levels of gapping that we've struggled to bring down. We typically have returned a significant surplus to both the city and the province for a number of years as a result of that gapping. We implemented a number of measures over 2014 and 15 in order to basically keep our staff positions filled to be able to deliver service. And at the same time, we increased the gapping that's in our budget from 4.8 to 5.8% in 2015. So we did both things together. It turned out they were more effective than we had anticipated. So as a result, in 2015, we are running very close to the line in terms of making our budget because our gapping has fallen to a level much, much closer to what is budgeted. We think, based on our experience in 2015, that we can probably reach our former gapping target of 4.8%, and that if that was reinstated, that we would be able to offer a level of service comparable to what we were originally budgeting for. So there is a cost to that, of course. Reducing gapping means paying more salaries for more people to be working at any given time. That's actually the largest of all of these service enhancements in dollar terms. And then lastly, one which is entirely provincial, the Vaccine Preventable Diseases Program has faced some challenges over the past several years as the province has broadened the availability of influenza vaccine during the Universal Influenza Program, which is going on right now. The pharmacies, of which there are 400 or 500 now, that offer influenza immunization all need to be inspected and monitored under a provincial program, which we do. So there are some costs associated with that. So we've asked for some assistance from the province on a one-time basis in order to meet that need in the community. So those are the 4 service enhancements which we've reviewed either in past years or this year with the budget committee of the board, which we're proposing be included in the 2016 budget. The summary of the base budget, well actually this slide is just the dollar value of those 4 initiatives. And you can see that the pharmacy inspection one is 0 net for the city because it's all provincial. As I said, the largest one is the gapping decrease, which is a net cost to the city of about $426,000. The final picture, when you put it all together with the base budget, efficiencies, and those 4 new and enhanced services, it comes to a 1.1% increase over 2015. Now, I want to point out that this does not include 2 things. It doesn't include the impact of collective bargaining. During a year when the collective agreements come to an end and bargaining is taking place, the city budgets for anything that may come out of those negotiations centrally. So we are asked not to put anything in our budget for salary changes which might come out of collective bargaining. Those will be added back in later once the bargaining is completed. And the second thing that it doesn't include is the student nutrition program, which we've typically treated as a separate decision, both at the board and at City Council. So if you look at the next slide, this is the financial impact of the student nutrition program enhancement, which the board adopted at its last meeting. So that would be added to our budget as a 100% municipal cost if City Council were to agree with the new 6-year plan that the board recommended. I'm going to pause there. That's the end of the presentation on the operating budget. To take any, Mr. Chair, if you want to take questions now or...
Dr. McEwen, thank you for the presentation. Just 2 brief questions. The provincial funding formula, we actually came out positive, but many of the other health units were at 0. What are the key drivers that actually made us come out positive? And the second question is, moving forward, is our baseline budget at risk?
The equity funding formula is, first of all, a population-based formula, so it is adjusted for the size of the population served, which the province had never done before in that way. Beyond that, the equity adjustment to the population is based on 2 general factors. One is the level of need in the population and takes into account factors like poverty. And secondly, the cost of delivering services. So for example, there's a geographic factor which is helpful to health units in the northern part of the province who have very large distances and where delivery of service is very costly. So service cost and service need are used as modifiers to a population-based formula. I think in our case, our population is not growing rapidly. We are a large population, and we have a population with significant needs. I think those are the 2 most important things that led to our funding being judged to be less than required. There were different impacts in different parts of the province. Some of the other health units and boards of health that received increases were ones with rapidly growing populations, like our neighbors in the GTA. Oh, I'm sorry, there was a second question you had. Is our base budget at risk? Typically, the province has not reduced base budgets. In fact, when they implemented the equity funding formula, they implemented it by adjusting the marginal increase in the budget. So the health units that were judged to be overfunded, in some cases very significantly overfunded in relation to what the formula recommended, did not receive any base reduction. They were just limited in terms of their growth or had no growth funding.
Thank you. Councillor Burnside?
Thank you. So I'm a little bit confused. The student nutrition program, you said, is 100% funded by the city?
Yes.
I thought I read somewhere about trying to move it from 14% to 16% funding. Is that something totally different?
Yes, well, in terms of the funding model, it's 100% municipally funded. The program does receive significant money from the provincial government, but it doesn't flow through the Board of Health or through the city. They fund it directly.
Okay. Thank you. So we're over budget by 1.1%, which is about 625,000, somewhere in that range, 626, right? Mm-hmm. We were asked to come in 1% under budget, so really we're about almost 1.2 million over budget, over what the city wants.
Above the guideline, yes.
Above the guideline, sorry, thank you. Okay, and then, in salaries, any increase in salary in the collective agreement hasn't been taken into account, so it's potentially worse than that. Okay.
Although the guideline we were given does take that into account, so.
Sorry, what does that mean, the guideline that you were given?
Well, we weren't asked to come in 1% below, including the collective agreement negotiation.
Oh, okay, so they'll take that in, okay.
2.1 is correct, yeah.
So, okay, my last question, and that simplifies things. In terms of the gapping, you want to go from 5.8 to 4.8 to maintain current service levels?
Yes, 4.8 was our gapping level for a number of years that we were never able to hit, and now we're able to hit it.
But what were we last year, 5.8?
5.8 was the budgeted gapping level, and we're going to come in just about that. but we've had to restrain hiring in order to do that. We've had to keep positions deliberately vacant.
No, I understand that. So the service level was, for this past year, was with a 5.8% gapping.
Yes.
So wouldn't, to maintain the service level, still be 5.8% gapping?
Yes, strictly speaking, that's correct. So maintain is not the right way to frame it. We'd like to go back to the service levels that we were budgeted for prior to 2015.
Correct, but so if we want to maintain, we should, because I'm just trying to look for efficiencies without compromising student nutrition programs and those things, which obviously I think we all see great value in. So I'm wondering if we kept to maintain the service levels, if we just left it at 5.8%, we'd save it $426,000. Is that correct?
I think, yes, that's the municipal portion, that's correct.
Okay, thank you.
Yeah. Thank you.
Hey, Councillor, did you, okay, I just want to follow up on one point from Councillor Burnside. We can't take the $400,000 hit and save the city that money, but what would be the cost of, on the provincial side, what money would we be leaving on the table from the province if we did that?
It'll depend on what the province is willing to fund in 2016. Obviously, if the province doesn't fund it, we won't spend it, and it'll be saved both by the province and the municipality.
Assuming that
typically, we've been asking for less than what the province has been willing to fund.
Okay, but if we don't fund that $400,000, I forget the number. What do we lose on the $426,000?
Yeah.
Means that we would lose just over $1 million on the provincial side.
Yeah, $1,086,000 is the
So we put in
provincial revenue.
We lose that revenue. We would automatically lose that revenue if we did it right off the bat.
That's correct.
So that's what you're leaving on the table if you don't put in your 25% at 426.
But wasn't that left on the table this year? Because we were at 5.8% gapping.
What was left on the table this year was the difference between what the province was willing to fund and what we had asked for. So that's the difference between the 1.3% increase and the 2.6% increase.
Okay.
It wasn't related to the gapping specifically. We actually lowered our budget by going from 5.8% gapping to 4.8 for the city in order to meet city targets. But that also meant that we weren't asking for the provincial money for that amount.
Okay, but and to Councillor Mahevic, when you say leaving it on the table, isn't that kind of like saying, well, there was a sale at the store for 75% off. I could have got it for 25%, and now I didn't get it?
That is one way of saying it.
Okay.
Basically, you know, if we, in a perfect world, we would have our programs better resourced. We have health standards that we need to meet, and in some areas we meet them, some areas we don't meet them as well. The province wants to invest in cities and in public health services because they pay off. At the end of the day, they don't have to spend as much money on hospitals and the sick care system. So they're saying, we'll put in $1 million, you have to put in your $400,000 though. So if you count, if you do it from a body's perspective or a person's perspective, and just using very round numbers, $400,000, if each, and plus $1 million from the province, $1.1 million from the province, let's say at $100,000 a pop, that's 15 people. In this economy, to be able to hire 15 people in public health to upgrade your services for $400,000, that's a deal. And the province knows that. The province knows that.
Okay.
That's why they do it. And it's a good carrot, and it kind of is one that you'd really have to think hard whether you'd want to give them.
But if that's the rationale you want to use, then really the budget should actually, the proposed budget should actually maximize provincial funding, and it shouldn't be
absolutely
shouldn't be where it is. It should actually be higher. So you're either all in or you're not.
Well,
right. If that's the way you want to see things, and that's very valid, you should actually be all in and not sort of go halfway.
Well, yes, I'll refer that to the, seeing we are actually technically in question periods of the medical officer fellow, let him answer that.
So just to comment, so many boards of health do that. The average ask for an increase on boards of health in Ontario is much, much higher than we ever ask for. There's probably not much point in asking for 10% because the province is unlikely to offer 10%. But it does make sense to offer the maximum what we think is likely to be coming forward. And we've typically been below that in the City of Toronto, and others have been above that, and so they've gotten more money.
And would it not be fair also to say that we've looked at 100% programs, for example, the Urban Health Fund, which is the fund that funds, for example, HIV, AIDS work in the community. It used to be 100% funded by the grant program, but you've brought it over here to basically maximize provincial revenue.
Yes. Whenever possible, where there are programs and services that fit within the Ontario Public Health Standards, which are eligible for cost-shared funding, wherever possible, we move them. Even though sometimes they're innovative programs which have started locally with City Council investment, we move them to maximize provincial revenue.
Okay. Any other questions of staff on the operating budget? Okay, speakers. Okay, go ahead, Councillor Doucette.
I am happy to move, receive, do whatever we need to do with this, adopt, that's the other word I was thinking of, thank you. We'll adopt the operating budget as before us.
Thank you. I'll speak to it, and John, do you want to go first?
Yeah, sorry, I was just going to make one point. The problem is this will ultimately go to the Budget Committee, right? And I don't know if they're listening, but at the end of the day, they're going to make some decisions. And my fear is if you go from your 5.8 to your 4.8% gapping and spend that $400,000, they're going to say, well, actually, we're going to have to save money, and they might cut it from another program. And so that's the risk that I think we're all taking if we adopt this as is.
Okay, thank you. I'll speak to it as well. It always is a balancing act, knowing that yes, the city sometimes doesn't have the resources, but I think at this point to put it on the table, I think the Budget Committee is aware that if we don't go from 5.8 to 4.8 on the gapping side, if we don't increase some money to the Urban Health Fund, that we are leaving provincial resources in public health. We're leaving them on the table, and we shouldn't be leaving them on the table. It's not good from a public policy perspective. So they give us a very strong carrot. They say 75% they'll pay for if you put in 25%. It's a very good bargain for the city to put in its 25%. And yes, we should be maximizing it every year. We used to maximize it every year. That chart suggests, there's a chart here that suggests, well, I know in the pre-Ford years, under Miller, but also under Lastman, we always maximized it. We maximized it whenever we can, wherever we could, and in some of those years, it was the province was only putting in 50% cost shared for many programs. So I think it is, the province knows that it gets good value for money. Every program that we put in here, it saves them money with hospital admissions, doctor's visits, and so on. And that's why they're very anxious for the city to be a funding partner. I think the Budget Committee knows that. If push comes to shove and they can't fund, then we're going to hear from them. But I think our going in position is that we use as much of the provincial offer as is possible. I think these recommendations do that. They were higher before, and staff have actually gone back and made cuts to the level that you see here today. My urging is to support the recommendations of staff. They are very defensible to the city's Budget Committee. Other speakers? John, do you want anything separated out from the 4 recommendations? Sorry? The capital's coming next. Oh, the gapping. You want the gapping voted on separately? Okay. So why don't we start with the gapping first? So the motion, we'll vote on, let's see, all the service enhancements. What number is the service enhancements? So I think what you're doing is you're moving a motion not to go forward with the decreasing gapping. Okay. Okay, they need a little time to work on. You're such a complex thinker, it's hard to, yeah, so we'll work on the motion, let the medical officer of health do his presentation on the capital budget, and then get back to this. Okay. Okay, so on to the capital budget request.
On to capital. Okay. As in most past years, you'll recall that our capital budget, which is not large, contains only information technology projects. Those types of development and replacement of IT systems are treated as capital by the city's budget process, and from a capital point of view, they are our highest need. We implement IT solutions often in order to enhance service efficiency, so many of our programs in which professional staff are working out in the community are being transitioned to mobile technology so they can access all of the tools of their work when they're at someone's house or at a school or at a community center. We're also using IT solutions to increase transparency of programs so that information and evidence is available on the web and on mobile devices for many of our programs. And we also are sometimes doing it in order to comply with provincial requirements. For example, the big communicable disease control system, which is being implemented, is a province-wide system that we need to comply with. The city's capital budget process requires us to come up with a capital budget for the upcoming year, 2016, as well as a 10-year capital plan, which of course changes over the course of the 10 years. It currently includes funding for 19 different IT projects. Just so you know, there is a formal planning process for this. The Toronto Public Health has an information technology strategic plan, which is the basis for the asks which we've made in our process. You can see on this slide on the left there's a series of objectives which are taken out of the strategic plan. On the right is a list of each of the IT projects and how they align with those objectives. This next slide is not an easy one to look at on the screen, but this is the format that is used for the 10-year capital plan. And you can see on the left a list of all of the projects, the 2016 request, and the amounts of money which we project would be required for the implementation of each of these projects is aligned with the year over the next 10 years. You can see some of the projects are in process now. Some of them are going to finish in 2016. Some of them are going to just start in 2016. Some of them don't start until 2023. So you can imagine the planning, things will probably change between now and 2023. But that's what the 10-year capital plan looks like. We also have prepared a list of unfunded capital requests. These are things which are also needs, but which fell below the threshold of what would fit within the debt-funded envelope that we were given. So some of these are also important, but we've ranked them lower in terms of priority. The reason I include them in the presentation and in the report is twofold. One, just so you know the full range of capital needs that we have. And secondly, because all of our capital projects are information technology, they are governed by a new process that the city has for assessing and approving capital IT projects. So that process has not finished yet. So in addition to being approved as a capital budget, all of these have to go through a decision-making process that's run by the city's Information and Technology Division. And these projects are at different points in that process. Some of them have made it through, and so we know that if they're funded in the capital budget, they will be implemented. Some are still in process, and if they are not approved in the IT process, then they won't be implemented even if they get capital funding. They probably won't get capital funding. So it's possible that some of these, which are in the 2016 recommended budget, may not end up being in our budget in the end. It's also possible that some of the unfunded ones might be funded, might be promoted because the city sees an opportunity or they're well aligned with something the city is trying to do. All of this is to say that that new IT approval process means we're not as far along in terms of being able to tell the board whether these are actually going to go forward or not. But I recommend that that the board approve the capital budget as a request pending the approval through the IT process. I think that's the end of what I was going to say. I thought there was another slide, but there isn't. So I wasn't ready. I wasn't ready for it. It says City of Toronto. Okay.
Okay, are there any questions on the capital? It's a lot of technology there. Okay, so let's go back to the operating budget. Sorry, is there anyone that wants to speak to the capital? Okay, so why don't we just take care of the capital, get that off the table. All in favor of the capital budget going forward? Okay, opposed if any, that's carried. So the way I'm going to suggest that we deal with, because if Councillor Burnside's motion requires a whole bunch of jiggling of numbers and it gets complicated. So if we just go to the handout here and go to page 13, you'll see the full implications of what Councillor Burnside is recommending. And there's two positions. One is that you keep it in. One is that you take it out of the request. Councillor Burnside's recommendation is that you take it out of the request. So my suggestion is we vote on that just as that motion, and then let staff jig the numbers if that motion passes. If it doesn't pass, then the numbers don't have to be rejigged. Okay, does that sound fair as a process? Okay, so the motion then is moved by Councillor Burnside that the decreased gapping from 5.8 to 4.8 be taken out of the budget submission to the city's budget committee. That's the motion. And now I'm going to ask who's in favor and who's opposed to that motion. All in favor of that motion, please indicate. Opposed? That motion fails. So now we go back to the whole operating budget. All in favor? Opposed, if any? That's carried. And that brings our meeting to a conclusion. So motion to adjourn. All in favor?
Did you vote on number 11 too?
11. Yes, we did. Yes. All in favor? Carried. Thank you, everyone.
Here we were calculating amount.